The 4 S's: sleep struggles, the spectrum, the science, and its solutions. And the panelists, the expert panelists for this session are Dr. Bharat Reddy sir, Dr. Indu Khosla ma'am, Dr. Sanjay Bafna sir, and Dr. Sushma Save ma'am. Bafna sir is from Bharati Vidyapeeth, Pune. Bharat Reddy sir is from Shishuka Hospital, Bangalore. Sushma Save ma'am is in charge of PICU and Neurology Epilepsy at Nair Hospital. And Indu ma'am, we're happy to have you back.
Sorry, now welcome back. Post-lunch session is on sleep. Am I audible? Yes, so now we will quickly start. We have like 37 minutes to go. So we will have a fast rapid fire round of questions. So our topic is 4S: sleep, struggle, spectrum, science and solutions. So we have our expert panelist already, Bharat Reddy sir, Indu ma'am, Sanjay Bafna sir and Sushma ma'am with us. We all know the healthy sleep duration. The American Academy of Pediatrics, has given all these guidelines. But is only sleep duration is only sufficient to say? Sorry? No, yeah. Yeah. So the thing is that not only the healthy duration of sleep is important, there are also other ways to say the child had a good sleep. What is a healthy sleep? Like going to sleep within, sleep latency is less than 15 minutes. There is no troublesome night awakening. And the sleep is actually, refreshed. When we wake up in the morning, we don't feel, very tired, sleepy. And also there is no excessive daytime somnolence. So all these, along with the proper duration, we should also have a good consolidated sleep. So that is very important. With this intro, I would like to just emphasize that why this session has been included as sleep disorders are commonly, not diagnosed, and we are actually not trained in our undergraduate as well as postgraduate days how to deal with sleep issues, and we generally miss it in our day-to-day practice. So this is just a quick revision like how to deal with the day-to-day scenarios. So my first case is the mother of a 1-year-old 8-month-old girl child presented to the clinic, and mother started saying that child has difficulty in initiating sleep. Though the mother is taking the child to the bed at 10 p.m., but the child is being playful. She always plays with the toys and finally goes around bed only at 2 a.m. And then she wakes up again at 5 a.m. crying for milk. She is bottle fed, and again she wakes up at 10 a.m. in the morning. Her afternoon nap is between 4 to 6 p.m. So my question to Sanjay Bafna sir, is this a sleep disorder, sir?
Can you go back? So I think
Yes.
definitely there is no question that we are discussing a sleep panel, so obviously this has to be a sleep disorder. But each and every line of your case history is pointing that there is a problem in this child.
Yes.
This child has no sleep schedule. There is bedtime resistance, lot of resistance. Child is having frequent awakenings, and that too getting sleep only after offering milk or something. So there is everything is pointing that there is a problem, and then of course the nap time. So this is classical case of behavioral insomnia of infancy, and we have 2 types in this. One is your limit setting time, where the parents don't set the limit. There is no sleep hygiene, no sleep scheduling, and then association. So this child, of course, there are the association. So it's a mixed type of behavioral insomnia. So very common problem. I think very important for office pediatrician, because this is the most common sleep disorder which they will see in practice.
Yes, sir. So our child has both limit setting as well as sleep associations. So my next question to Bharat Reddy sir is, what is a normal sleep pattern in infants, and are night awakenings common in infants?
So first of all, normal sleep pattern in infants, we do have a change which happens in your sleep patterns over a period of time. So what happens between 6 months is where you have start having these long stretches where you should be able to sleep at least 4 to 8 hours at a stretch. By 6 months to 12 months, 8 hours start going up to 10 hours. And by 12 months, you should be able to sleep 12 hours at a stretch, which is what we call as sleeping through the night. Night awakenings are common. So why do you actually have awakenings is because our sleep normally transitions between REM and non-REM. So we're going between REM, non-REM, REM, non-REM. This is what we call as an ultradian rhythm. So when, even as adults, we transition between REM and non-REM, we all have an arousal, or we tend to wake up a little bit, right? But we go back to sleep on our own without realizing it. So which we call as self-soothing behavior. So in an infant, waking up or moving a little between your REM to non-REM transitions is normal. So first thing we always counsel parents that this is normal. But you doing something to make your child go back to sleep is not normal. So a child waking up or a child moving, being jittery, making sounds also happens during these transitions. So night awakenings I would see is normal, but requiring intervention to go back to sleep is probably what is not normal. So in actually your child, it is a lot of limit setting type, because the child wakes up at 5 o'clock and then goes back to sleep. So that 5 a.m., the stretch which you're seeing is actually 10 hours. So I still think it's only the limit setting problem.
Yes.
And awakenings should be considered normal in this child.
Yes, okay, sir. So, ma'am, Sushma ma'am, my question is, which other medical condition can also cause sleep disorders in infants and toddlers?
So as we know other conditions, like if you take it as a respiratory, so like asthma, so during the night time there's a decreased oxygenation, so hypoxia, that can also lead. And the other conditions is because of the pain whether the child has got, so arthritis. So whatever the conditions you have listed, in addition to that,
yes,
so arthritis is another condition, the child cannot sleep in the night. Then there is a neurological conditions like hyperactivity child or attention deficit, autism, cerebral palsy. So if they are not sleeping because of their neurological problem per se, because there is a sleep architecture which has been disturbed, and even they are on an anti-seizure medication. So that also causes a problem with their neurotransmitter pathway. So those are the conditions will happen.
Yeah, so we should always look for other condition which can cause disturbed sleep, like an atopic dermatitis, itching and other reasons. Yes, ma'am. So my question to Indu ma'am, like what do we do with all these kids? How do we explain the parents and how do we treat them?
So as Bharat pointed out, the problem was more of limit setting here. So here the training is also of the parents, and they have to be first counseled what is sleep hygiene, how the child should sleep. And many parents whose babies are growing up, they are used to feeding the child every 3 hourly, 4 hourly. And then that habit does not go, and they feel that whenever the child gets up in the middle of the night, the child has to be fed or the child has to be rocked. And today's parents have less tolerance to their child crying also. So all these factors are very important, that when we have to counsel a patient like this, that the parents should be on the same platform. And then only we can actually train the child. Here, it is not the problem of the child. And if you were to normally see a baby who is born, initially the first 3-4 months, the child will get up, take short naps in a day. So they have polyphasic sleep. But by the time the baby is around 5 to 6 months of age, melatonin also starts getting produced in the body. Their body reserves are there. They can actually sleep 5 to 6 hours. So that has to be told to the parents. Now your baby does not require night feed. Once you have explained all that to the parents, then you need to tell them to establish a bedtime routine. So the bed has to be associated for sleeping and not for playing. So if your baby is actually sleeping, like in this case was sleeping at 2 a.m. So if I have to train this child, I will tell the parent, take the child to bed at 1:30. Okay, and avoid evening naps, and then so within half an hour he should sleep, and then gradually work backwards and gradually start waking him up early, and don't let him nap after 4 p.m. in the evening. So this is what we need to train them to develop a schedule. So establish a proper bedtime which will gradually develop in this child, and then develop a consistent pattern of sleeping. It should be the bed should be, environment should be good for the child to sleep. And then if the mother is breastfeeding, so many times babies are breastfed and they go to sleep on the breast. So the child has to be unlatched from the mother when the child is drowsy, and let the baby be put to bed, and then favorite toy is around with the child. So the child plays with it and goes to sleep. I mean, no strong lights, TV shows, screens, all that should be avoided. There's other way of doing a rapid, like you can do it gradually, or you can do it, let the child cry it out. So even if the child cries, the parents should be told, let the child cry out. So the others, you can do it little more gradually. Okay, today I will allow my child to cry for 5 minutes, tomorrow 10 minutes, 15 minutes, like that. So I think that main counseling is the parents. Yeah.
Yes, ma'am. And now many of the parents, like they follow the Western trend. So there is always a confusion whether the child has to sleep in a separate room or co-bedding or in the same room. Which should we advise, ma'am?
So I think this is something very social. Yes. And I hear, though there may be norms for it in the Western world, may be different from what we would think. Mm-hmm. So maybe I would think in an Indian setup, maybe the child is 1.5, 2 years. I think it's high time that the child is not at least co-bedding with the parents. Yeah, and then we can, so no co-bedding with the parents. So initially when the mothers are breastfeeding, there was a study from the south of the country that the smaller babies were being breastfed through the night. I'm talking about like less than 6 months. And And did that cause a sleep disturbance? The answer was actually no. So therefore, it is okay initially, and then slowly from co-bedding to it can be in the same room, and then maybe by the time the child is 2 years old, I think we can even look at moving the child out of the room. But I think it is a lot of social thing. You want to add something?
Yeah, sir. So I think in our, we do a lot of sleep coaching as well. So I think one of the highlight which Dr. Indu was trying to raise to common pediatricians as well is to understand that we have to start doing sleep coaching more often. And sleep coaching we do in two ways. We give the option to the parents saying, do you all want to co-sleep or not co-sleep? Co-bed or not co-bed? It doesn't matter anymore. You can still sleep coach the child as long as you're able to not react when the child is crying. Yeah. So a lot of parents, even if the baby is on the same bed, the baby is trying to latch on to the mother. Mother turns the baby around, makes the baby lie down and pat the baby to sleep. If the mother is able to do that, co-sleeping doesn't make a difference at all. Yeah.
Thank you, sir. Now we are moving to an important case. So this is a 12-year-old girl child with Down syndrome with obesity presented to PICU with pneumonia. This child PCO2 was 56. The child required NIV support. And gradually she recovered and then she was shifted to ward. During the rounds, the pediatrician has noticed that child is snoring loudly. And on examination, anyway, she was obese and also had tonsils were enlarged 4+ with high arched palate. So now my question to Bharat Reddy sir is like, how do we approach this case and then how do we ask further questions?
Can you go to the previous slide, please? So
yes.
We basically need to understand this is a child with a genetic syndrome.
Yes.
It's given that they're going to have sleep issues. So a child with Down syndrome plus obesity are two existing comorbid factors to cause severe sleep disorder breathing. So we ask a lot of the questions towards sleep disorder breathing. But for general pediatric practice, we start off with basically the Bears questionnaire. Yes, we start off with asking about bedtime issues. Is the child resisting going to sleep? Is the child having difficulty to go to sleep? Is it taking very long? Is there insomnia features or not? So we talk about bedtime issues. Is there excessive sleepiness during the day? But as we know, in pediatric, it can appear other way around. You may not have to have excessive daytime sleepiness. You may have hyperactivity. So we ask for hyperactivity and inattention. A stands for awakening and night awakenings. Are they waking up multiple times in the night? R stands for regularity. Are they sleeping at the same time every night? Is there a difference between your weekday and weekend sleep time? And S stands for snoring. This Bears questionnaire, which covers these 5 questions, have been validated throughout. And it says that literally 80 to 90% of sleep problems you'll be able to pick up if we ask at least these 5 questions. So in your child, I would still want to know about the sleep resistance. Yes. We would want to know about daytime symptoms, nighttime awakenings, regularity, and snoring. Yes. That being said, I just want to add a point that in children with genetic syndromes, irrespective of whether they have sleep symptoms, history or no history, they need to be evaluated. Which means that if you see a child in general pediatric practice who has Down syndrome, whether they have symptoms or no sleep symptoms, you have to refer them for a sleep study.
Yes, sir. So now we have answered sir's questions. So this child doesn't have any problem in the bedtime routine, but the child definitely has a lot of daytime symptoms. Child is lethargic and tired since last a few months, and also parents have noticed the child is having frequent night awakening and also has history of loud snoring and open mouth breathing since last 1 year. So this child, ma'am, Sushma ma'am, my question to you is, as sir said, all the syndromic children are higher risk of sleep apnea. Why are children with Down syndrome are higher risk of obstructive sleep apnea?
Yeah, so as sir also has said, it's a syndromic. So in Down syndrome per se, they are gotten a flat facial profile.
Yes,
okay?
ma'am.
And then there is a mid-facial and a mandibular hypoplasia they have. So it's basically anatomical. Then there is a neuromuscular. And then there is a functional. So that is what the problem causes in Down syndrome to get into a obstructive sleep apnea. So basically is their anatomy and their hypotonic, micrognathia, retrognathia, that all compromises the airways in this child.
Yes, ma'am. My question to Sanjay Bapna sir, like why should all children with Down syndrome should undergo sleep apnea screening even without the symptoms?
Yes, so I think Bharat has partly answered that question. So yes, basically when we go through the Bears screening, or then we can have questionnaires and we can have questionnaires for obstructive sleep apnea. We know why these Down syndrome children are a very high risk. The incidence of OSA in these children is almost to the tune of 40 to 60%. And if you take the history, you may not get history in 10 to 20% cases. So there is a poor correlation between your PSQ or the Bears sleep scoring or the sleep history and actual OSA. The OSA incidence is so high, almost touching to 50 to 60%, that you need to have more sensitive parameter or sensitive test to undergo. And therefore, the recommendation now, all the international recommendation is to do sleep study for all the children with Down syndrome at least by the age of 4 years. So they should have at least one sleep study, and then of course depending on what you get on the sleep study, you will do the follow-up and the sleep study later on. But detailed evaluation. So beginning point is of course for the pediatrician to understand that they have a problem. So start with your first question whether the child snores, go to the bears, do an ENT evaluation, craniofacial evaluation, ENT reference maybe, and then of course refer to a specialist for a detailed evaluation, and most of them would definitely should undergo a sleep study.
Yes, sir. So take home message is any child with Down syndrome, think about obstructive sleep apnea, and then at least before the age of 4 years, ideally they should have one sleep study done.
Just a point to add, Abhinaya, to that is it's not just Down syndrome. We have all genetic syndromes. So we have shown studies even in Prader-Willi syndrome, children with syndromic obesities, mucopolysaccharidosis. So as a general pediatrician, if you see a syndromic child with some degree of facial dysmorphism, they have shown that clinical history and sleep studies don't correlate. Many of them don't have clinical history. But when we have done the sleep studies, they almost always show severe obstructive sleep apnea. So as a pediatrician, we need to understand that any genetic syndrome with dysmorphic features, irrespective of history, we need to do sleep studies.
Correct. Thank you, sir.
So even with, So even with nutritional obesity, we do see a significant amount of obstructive sleep apnea. But there the history is quite significant. So we start seeing definite history. So we say in non-syndromic obesity, you need to do a detailed history taking and then subject them to a sleep study. In children with genetic syndromes, the studies show that the history is not correlating because the history comes much later. But these children at a very early age, for example, Down syndrome, they said by 4 years. So before 4 years itself, you see 50-60% have OSA.
Another category here is neuromuscular disorders, where there are clear guidelines for DMD, SMA, where you need to definitely do a sleep study. You need to monitor them with lung function and something called as cough flow rate, because there it's a game changer. It's a life changer for them, because what kills them is respiratory morbidity, and you can totally prevent it if you can diagnose a sleep disordered breathing and put them on NIV much in advance before their lung health starts to deteriorate.
These children who are at high risk, apart from history and your PSQ scoring, PSG is of course gold standard, but you can start with some investigation like audiovisual recording at home, maybe a pulse oximetry. That makes the parents also convincing that, okay, they start observing how the child is sleeping, and they will come with the history that yes,
correct,
there was a snoring.
Easy to convince them also. Yes, sir. So coming back to our case, so based on the above history of our child, Indu ma'am, what investigation should we order now?
So I guess you're asking about the investigation of the sleep issue.
Our child.
Yeah, the sleep issue and not, because this child has many other issues.
Yes.
So when it comes to sleep issues, this kid, when the child recovers and is well, I would do a sleep study, and I would do a level 1 sleep study, which is a attended sleep study with the technician. This child should have even all the monitoring like the ETCO2, the camera, the works. I can list all the things that you require, but this child doesn't, so many of these sleep studies are done at home, and it originates from how adults are doing sleep study. For adults, we do sleep studies at home, but for pediatrics, that is not validated as of now. And for a child like this who is a complex OSA, we need to do a level 1 PSG. So that would be the first thing that I would like to do. I can do an early morning ABG, but that you have already documented. Of course, that time the child was sick.
Yes.
But in this child, early morning ABG, if it shows me a high CO2, again it's a marker that this child is hypoventilating in sleep and therefore is having a problem.
Yeah. We also order an
ENT evaluation is the other thing that I would
for this child. So as ma'am said, PSG is required, and also ENT evaluation. The one point to highlight is, though we all frequently order X-ray nasopharynx, we have to remember it. The size of adenoids do not correlate with the severity of OSA, and also there is again a risk of radiation and other things. So best way is again a nasal endoscopy, and then to confirm whether the child has sleep apnea. So in our kid, the AHI, as you see, it was 31.1, which is nothing but apnea-hypopnea index, which we will be discussing it. And the number of desaturations were like almost, if you see, they were 21.5 events, and then the least oxygen saturation was 76. So my question to Bharat Reddy sir is like, now we have a sleep study report. So if a general pediatrician is seeing the report, like what parameters they should see and how should they interpret the report?
Sure. So I think this is what you will receive once you send for a sleep study. This is a report you will get from your sleep lab or your sleep doctors. And let's go through some of the parameters so they can understand what we're seeing. So the first, you see what is called as respiratory analysis. You see something called as obstructive, mixed, central. So obstructive refers to the number of obstructive apneas, central to the number of central apneas. And below that, you have something called hypopneas, which is showing 147. So apnea means while we're doing a sleep study, the entire airflow is completely absent for more than 2 breaths. Whereas hypopnea, it means that the airflow is reduced but not completely absent. So we follow something called as an ASSM guidelines by which we classify these. So we keep going through the sleep study, we decide how many apneas, how many hypopneas. Throughout the entire sleep study, we document these. So this is saying for the total sleep time, there was almost 183, A plus H is apneas plus hypopneas, 183 were there. That divided by the total sleep time. So per hour, you're having 31 apneas or hypopneas. That is what the report actually means. Each hour, 31 times the child has an apnea or a hypopnea. Then you correlate it to the oxygen saturation. You look at the saturation, you said almost 113 times the child is desaturated. So the definition of desaturation on a sleep study is 3% change in the saturation. It can be from 100 to 97, it can be from 99 to 95 also. That is still a desaturation. So remember, in sleep, for us that 3% is significant. You being continuously at 95, 93 is not important for me. You desaturating, going back, desaturating, going back. That is more important for us. So which is what we document as the number of desaturations. So every time you have a small apnea, you drop by 3%, but you return back to normal. So baseline saturation is less important for us than the number of desaturations. So 113 times through the night this has happened, divided by the total sleep time, so almost 21 desaturations per hour. So these both are very significant for us. We first classify the AH high, that is apnea hypopnea index, as normal, mild, moderate, severe.
Yes.
Normal is less than 1, 1 to 5 is mild, 5 to 10 is moderate, more than 10 is severe. So in this child, your AHI is almost 31. So it falls already into your severe category. Mild will be 1 to 5, that is where we do all other things which require. And we also follow something called as an ODI, which is your oxygen desaturation index, but we really don't, it's not very validated.
Yes.
We use that along with AHI, but for us mainly this child has severe sleep apnea, there's nothing much to think about in that child.
Yes, sir.
So we also need to look for just the interpretation. Yeah. So you look at something called CO2 there. So here they've already done a capnography. So you're doing an EtCO2 or a transcutaneous CO2. We see how much of the carbon dioxide is increasing, right? So normally, if the CO2 levels are more than 50 for more than 25% of the sleep time, that would be significant for us to label it as hypoventilation. Hypoventilation is very significant for us in syndromic children, neuromuscular children. That means they are not breathing sufficiently, which is a clear indication we need to go for NIV directly. Either we do ABG or we do a EtCO2. So I think for pediatricians, you need to look at these 3 things. Look at the respiratory analysis, see how much the AHI is. Look at the oxygen desaturations, how many desaturations are happening. And look at the carbon dioxide. Is the carbon dioxide going up or not? Based on this, our treatment can easily vary.
Yes, sir. So because we also get many times sleep study report, like how to interpret even from the other colleagues. So I think this is very important takeaway, like what exactly we should look in the sleep study report. It also has other parameters like how was the sleep staging and how, was there any leg movement. All those also add some values. So my next step done for this patient was ENT reference was done. They had done a nasal endoscopy and then they confirmed the presence of enlarged adenoids and tonsil. And this child was advised tonsil adenoid removal. My question to Sushma ma'am is, because the child anyway has a severe OSA, should we directly put the child on any NIV or do a tonsil adenoid removal first?
I think we had a lovely lecture by madam, and the take home from this for this question should be what? What do you think?
Audience.
It has to audience, yeah. Yes, absolutely. So we need to remove tonsils and adenoids. That will be our first line of a management.
Yes,
but for any reason, if the surgery has been delayed or contraindicated, then for that point of a time, we can use an CPAP. So that is what my take will be.
Yes, ma'am.
What Abhinaya is trying to point is, since this child has a severe OSA, Obviously, the point well taken that we need to take the tonsils and adenoid, but you start them on CPAP because this is a severe OSA. This is 23, I think 32.
Yes, ma'am.
So this child would land into trouble if you just do not support the child with CPAP. So you need to give them CPAP, stabilize the child, and simultaneously, of course, arrange for your tonsil adenoid removal, and post-operative also.
Yes,
this child
my
would
next
need
question
an
Because
Ma'am,
this
was
child,
that-
this child, I would even do a 2D echo because this is a long-standing OSA, and I would admit this child. I would not do a day. Many times tonsil adenoids you operate and you send the same day. So that kid, I would not even do that for this kid. And the other thing is, this child also after the tonsil adenoid removal may still will need CPAP support because he has got obesity. So lifestyle changes is going to take time to come get better. Plus the child is Down syndrome. Now Down syndrome, by the time they're adults, almost 100% of them have OSA. So this kid is going to be, even after the tonsil adenoid removal, requiring some NIV support. So this child will need a continuous evaluation, follow-up for all that. So 2D echo, inpatient care, proper monitoring, anesthesia team should be, so whenever we have children in our hospital who are in this category where we have to do a tonsil adenoid removal, we take the anesthesia team on board even before the surgery. And we have found that most of these kids take a lot of time after surgery to get the oxygen removed. They take longer time in the recovery, and they should be kept and observed before you can actually send them home. Okay, now you were asking about DICE,
Ma'am
right?
has already,
we did it in the
spoken
last
on
lecture.
DICE, so we will
Covered
now
it.
skip that.
Yeah, we will.
So, Abhinay, in this child, more than your nasal endoscope, sorry, more than the nasal endoscopy, we should have first gone for a DICE directly.
Yes, sir.
So there was no role of a nasal endoscopy with an ENT. This is a child with Down syndrome, obesity, having severe OSA of more than 31. Your drug-induced sleep endoscopy should be the first choice rather
Yes,
than
sir.
doing a nasal
So,
endoscopy.
So this child again dies.
I'd like to add, Bharat, I do agree with you where you're coming from, but this is like on the face. This is staring on the face. So should we still do a DICE? I mean, I would do a DICE in the previous case which I showed, was where there were some gray areas. The tonsil adenoid was not that big. Still, the child had a proper. I would think the DICE here would be either or.
Yeah, so here the advantage of your DICE would be for your perioperative or preoperative CPAP therapy.
Yes.
So here, showing such severe obstructive sleep apnea, you may not see that much problem in the DICE actually. Then you're clear that it is adenoids and tonsils causing this AHI of 31. So I would not do preoperative CPAP. Otherwise, like how Dr. Bafna said, if the DICE is showing severe soft tissue collapse, I would do preoperative CPAP, post for adenotonsillectomy, and then manage post. Otherwise, post-surgery, you will face significant problems.
Yes. So in this
Bharat,
child,
this child has Down syndrome, so tonsil adenectomy may not only be the answer in this child. Yes.
This kid has something totally on the face. Any other kid, I would have thought, yes. And DICE, of course, tells you the level of obstruction, the severity of obstruction. Having said that, DICE has to be done under very controlled environment with the BIS monitor, with the trained people, because I did one DICE just 2 days back in another corporate hospital where the people are not used to doing it and they just totally doped the patient. So then there's the whole purpose is lost. So the child has to be in a sleep state, not in deep anesthesia. Only then you will actually see what happens really to the patient in sleep.
yeah. So I think now we have discussed about DICE also. So now we are now distracting from the case. So we have seen how to deal with any syndromic child and a Down's child. The scenario is different. But our most common patients are a normal, neurodevelopmentally normal kid with simple adenotonsillar enlargement with sleep disordered breathing. So my question to Sushma ma'am is in a child with simple tonsillar enlargement with sleep disordered breathing, how to approach further?
I think the experts sitting beside me, I think sleep study.
Yes.
Yeah, that should be the first investigation which we should go for.
Yes, ma'am.
And then so just in a want of a time, then if you have a mild OSA, then we can ask the medical therapy,
Management.
which will be intranasal steroids and a combination of intranasal steroids and Montelukast. But then there is a black box warning has been given for a Montelukast. That is what we have to be careful about. And obviously, if it's in a severe, we'll refer to them.
Just to add to what Dr. Sushma Save has to say, that if you look at the guidelines of the American Association of Sleep Medicine versus the ENT person, so if you have the ENT guidelines, there's a tonsil adenoid Nicaldo. sleep study क्यों करना, उतना पैसा उसमें जाएगा, इसमें जाएगा. But when you go to the ASM, they say no, first do a sleep study, and because 30% of children even after having removed tonsil adenoids may still have sleep apnea, so you need to really follow up and see what's happening. So I feel there are the truth is somewhere in between. I feel you have to decide is each case, and if it's a simple OSA because of tonsil adenoid, and if it's a mild OSA, here you have done a PhD, that's why you know it's mild.
Yeah, otherwise,
but you can get it.
my
Otherwise
next
you wouldn't know it's mild or not.
Bhavna sir is that only, like, is PSG mandatory in all patients before TAR in a like simple adenotonsillar enlargement?
So basically, let's understand why why we keep saying PSG is gold standard. There are few reasons. One is PSG will actually tell you whether there is OSA or not, diagnosis.
Sir.
Secondly, it will tell you the grade, mild, moderate, severe, because you are,
Treatment is changing. Yes, sir.
Thirdly, it will help you in following these children. You have something and then you followed what happened. So this is how it helps. Having said that, as Indu was saying, we have simple OSA for the audience to understand. The simple OSA is you have a tonsilloadenoid hypertrophy which is causing OSA, which is the most common cause and which you will see in your day-to-day practice, and an obesity which is a cause of a simple OSA. And you have a complex OSA where you have a craniofacial abnormalities, we have Down syndrome, we have other syndromes, neuromuscular disorders, and combinations of all these. So that's a complex OSA. There is no question that complex OSA, you suspect SDB, do a PSG. And recommendations we have already spoken that many children at some age you have to do. So there is no doubt. Only question is healthy child walks into your clinic, some SDB feature, you have a tonsilloadenoid hypertrophy, would you do a PSG? The recommendations, ENT people, American Otolaryngology Association says, no, remove the tonsils and do PSG. If the symptoms persist, follow these children. Obviously, if you do tell them PSG, they will run away from the ENT, so they obviously would take that pathway. But the AAP recommends that all children, irrespective of simple or complex OSA, if you want to do TAR, do a PSG.
Yes, sir.
Coming back to Indian setting, I think it's not feasible, not practical, and not possible. So we all also follow this same practice. Healthy child, tonsilloadenoid hypertrophy, no other complex feature, remove tonsils, follow them closely. If required symptoms persist, either do DICE or maybe PSG and then decide. So that's what we are following. But obesity with tonsilloadenoid hypertrophy becomes a complex OSA, so be careful in this.
Yes, so this is an important takeaway from sir and all the panelists. Only simple, no risk factors, we can, in the resource limited country like India, we can safely remove tonsil and follow up. There is even one risk factor where it can be something more than simple, then we have to proceed for PSG.
Only thing is you can think of audiovisual recording, you can think of pulse oximetry, nocturnal pulse oximetry at home. All these, some simple measures, like there is an OSA questionnaire which is available. So all this can be utilized to make it more objective as possible.
Yes,
but
sir.
PSG in every child, probably not possible. We are not
possible.
yet there.
Yes, sir. Yes.
Ma'am, question for you, ma'am. So in this scenario, whether the early morning blood gas will be helpful, no?
So this child, if you see the...
Hypovent, okay.
No, you're talking about the second nominal tonsil? No. In a Downs, yes, but in any child who is hypotonic, and this kid, in fact, if you saw the first report, the CO2 was already high. So in that kid, you will definitely have a clue. But in a normal tonsil adenoid, you may not really have a high CO2. Yeah. So in sleep, before they get up, ideally you should do a capillary before waking them up. Yeah. Before
And according to ASM, even for all children, we have to see CO2 because they can have obstructive hypoventilation. That is also there. So now we are going back to our case. So how to follow up children after a tonsil adenoid removal, and how reliable are the clinical symptoms compared with polysomnography, both in a normal as well as in a syndromic child?
I think we've already discussed this.
We
About 20-30% of patients, even after tonsil adenoid removal, will have symptoms of OSA. So definitely you should follow them up. Anywhere between 3 to 6 months, if you feel that history is strong and they have symptoms, you may want to do a repeat sleep study. Look at other things, like sometimes there are mouth breathers and they still do not learn. Even after removing tonsil adenoid, they're still breathing through the mouth. So some kind of a myofunctional therapy can also help them. If they've have dental malocclusions, try to correct. So look at all other reasons why these kids could have an OSA and address that. Some people children may require CPAP if it was a malacia, which is a problem, a pharyngomalacia, and therefore, and many children who have a plain tonsil adenoid, they have recurrent either OSA or they may have recurrent infections. They are sometimes failing to thrive. The moment you remove tonsil adenoid, they actually start becoming obese, and that may become another. There are enough studies to show that they become obese after tonsil adenoid removal, and that can become another risk factor. So all these things you need to monitor their growth and their symptoms. You ask how reliable are clinical symptoms. So symptoms may not tell at all, and polysomnography may have to be done in this set of patients on a follow-up if you have lead symptoms.
Yes. So now we are continuing with our Down syndrome. So on follow-up after 3 months, we have done a repeat PSG, and that showed an AHA of 15 per hour with an ODI of 7.1, and there was no hypoventilation. So my question to Dr. Bharat Reddy sir is how to initiate NAV in this kid, and how will you use CPAP, or will you use CPAP or a BiPAP?
So in this child, firstly, we just to highlight the high risk factors for relapse or recurrence. Child had obesity,
yes,
child was syndromic, child had AHI more than 10. So all these are high risk factors that we know after adenotonsillectomy they're going to come back.
Yes.
Which was why I insisted we do perioperative CPAP. We started before, and like Bhavna sir said, we continue it after. This child, your CO2 was very high during ventilation, during the child's admission. But during your sleep study, the CO2 was normal.
Yes.
So I would start on CPAP. We monitor this child on CPAP, and then we do something called as a titration study. Right? What is a titration study? Is we do a sleep study on the CPAP, and we tend to adjust the pressures of the CPAP to keep seeing how much pressure is really required. So you do the sleep, first you initiate your CPAP. After 6 weeks, we do a titration study. And with that, we try to see what is the actual pressure which is required. Some children, we see the CPAP may not be sufficient, we may have to move to BiPAP. Many children, we see the CPAP is sufficient and plan that. The main problem we face with CPAP and BiPAP is the device. So is the device and the interface. So the interface is the mask that you use. How do you use the mask? Which is the correct mask? Acclimatize them to the mask. Desensitize them to the mask first. Then we put in the pressure. We usually start at very low pressures, and after that, on a PSG with a titration study, we keep increasing the pressure slowly till we get the correct pressure that they require and can tolerate. After that, you need to follow them up regularly to make sure that the compliance, it's pretty much like asthma. You check the interface, you check the device, you check the compliance and whether they're using or not using it. Our aim is minimum of at least 4 hours over 30 days should be used. If that is used, we tell they are compliant. So I would go in this stepwise manner.
Yes. My final question to Sanjay Bafna sir. On follow-up, we found that the child, after following all the steps which doctor suggested, the child is still poorly compliant with NIV mask, and child is keeping on removing at night. Anyway, they are Down syndrome. They don't understand also much. So how to address this issue, sir?
So I think this will be a three-pronged approach. You need to have a technical adjustment, which I think some of them Bharat has already said.
Yes, sir.
Some behavioral modification and lot of support, which is all required. Technical adjustment means the most common cause. Compliance is already defined. 4 hours you need to at least have, almost for a month. Then it is a compliance which
Yes,
is
sir.
there. But most important reason for non-compliance is the mask.
Yes.
Or the interface. So you need to check whether the interface is proper, whether it is snugly fitting, or if there is causing a lot of discomfort. We usually use a nasal interface now, and the nasal pillow, nasal mask. These are better interfaces because they are well tolerated. If there is a mouth breathing, you can use a chin strap to remove the leak. Second thing which you, as already pointed out by Bharat, start with the low pressure. So if the pressures are very high and if that is causing the trouble, you come down on pressure and start with the low pressure and then again slightly build up the pressure. Third is you can increase the RAM time. RAM time is the time which is, from starting the therapy, the time taken to reach that peak. You are set at 10, suppose CPAP of 8. It will start with 4 and gradually it will build up to 8 for over and half an hour or 40 minutes. So that RAM time, if you keep it as low, then gradually child will get used to that. And then of course, behavioral modification. How do you do that? Most of the time, this Down syndrome, I think I will admit this child, at least for a day, because I don't think it is possible to do it at home. We need to allow the child to play with the mask, maybe put the mask and he is reading the book, he is watching TV during daytime. So they get acclimatized to the mask. That's how it happens. Otherwise, it's a very, very difficult procedure. It takes almost 5 to 7 days for them to get to use. And lastly, support. And also educate. If you tell them what is the use, how it improves the sleep quality, how it will make the quality of life better, then they understand. This is a small child, but older children, they would become more compliant. So this is how you would go about
Yes, so sir has correctly summarized the ways to correct all this measure. So our time is up, so I quickly summarize.
Just one sec. For
Yes,
the CPAP, ma'am, sorry, but it's just the CPAP, the interface is very important. So that
Yes,
has
ma'am.
to be taken care
Yes,
of.
ma'am. Thank you, ma'am. So the take-home message would be to take a correct sleep history, and to see whether child has any risk factors for sleep apnea. If it is there, go for polysomnography. If it is only a simple adenotonsillar enlargement, then we can proceed to directly tonsil adenoid removal and then follow up. I think these are the important takeaways. Though this is one video, I think I'll just put it in the background. I'll make it as an audience question. It is in the sleep, if it's not clear. The time is up, that's why I made it audience question. Oh. Anybody from the audience? The patient's face is not clearly seen, so that's why I've written is this happened in the sleep.
Yeah.
Yes.
So if you look at the child, so he's muttering to himself. He's got up first of all, so his arousal is there. He's talking to himself. We don't know. We are not able to understand. And he started walking. So there's a confusion arousal with night walking. So that is what is being
Yes,
video.
ma'am.
Am I right?
Yes, ma'am. Thank you so much, ma'am. Thank you.
Non-REM parasomnia.
Yes.
That's what.
So basically,
Yeah, it is normal. It disappears with time. Yeah, lack of time. We will not discuss.
Yes,
But this
we are
is
not
what you all will see
discussing-
as pediatricians.
yeah, NREM parasomnias episode not remembered in the first half of the sleep. Thank you so much.
So non-syndromic OSA, if you just have simple tonsil, as I've mentioned, 30% of even simple tonsil adenoid patients may have either recurrence of adenoid tonsil tissue, or they may have other factors like the tone of the upper airway which may cause them to OSA. So you have to follow them up, and you have to see by if there are clinical clues, you will repeat between 3 to 6 months after the surgery. You may have to repeat a sleep study, and just history alone may not be enough, but you should look for clinical clues.
They have what we call as high risk factors for recurrence. One is that AHI should be more than 10. If it was more than 10, we have to repeat it, or they have obesity.
Thank you.
Thank you, Dr. Abhinaya. Thank you to all our panelists, and thank you to the audience for staying awake and alert and interactive for this sleep session. I invite Dr. Rajesh Chokhani, sir, if you could please felicitate our panelists today. And Dr. Abhinaya, of course. Thank you, everyone. I now hand over to Dr. Abhinaya to introduce our next speakers.
Hello. So now we move on to the next important session of the day. Our session is 4 C's: chronic suppurative lung disease, confusion, clarity and care. We have all the eminent pediatric pulmonologists of the country here to discuss on the CSLD. Our moderator is Dr. Parmat Chandani sir, and our panelists, I invite Parmat sir And also our panelist, Dr. S.K. Kabra sir, I invite you sir. And then sir needs no introduction. He is the father of Indian Pediatric Pulmonology. And then we have the Sneha Varki ma'am. Ma'am is pioneer in CF and she is a HOD from CMC Vellore. And we have Rashmi Kapoor ma'am, another eminent pediatric pulmonologist from Kanpur. And then we have Kaustubh Moite sir, our leading interventional pulmonologist. I invite Parma sir to take over. Thank you sir.
Thank you, Inde Madam, IIP Mumbai, and entire team of SRCC Hospital for conducting this CME. This year I was thinking nobody is conducting in Mumbai. Last year we had in Wadia, and this year in SRCC. So I am talking to the most well-learned panel here. Okay. So in the country, I said, there are people who have inspired a lot of students across India to take up pulmonology, including me, because of Kabra sir, Rashmi madam and Sneha madam. And we have been into pulmonology for last 12, 15 years, whatever it is. And somewhere we look up to them. When we see them, we get inspired. We try to do things probably not as equal to as them, but we are trying. So coming to our panel discussion, this is about suppurative lung disease, and all of us know what is meant by suppuration. Suppuration means it's necrosis and pus formation. Okay. And whenever there is suppuration or necrosis, there are two things that we commonly do. One is either we have to drain it or we have to give antibiotics, isn't it? So the common symptoms when it comes to lung disease, that is lung suppuration, it's suppurative lung disease, is the wet cough, the chest pain sometimes if it is outside the lung and between the thorax. Then fever, foul smelling sputum is also one of the symptoms, and one of the signs which may point towards suppuration is clubbing. That is because of suppuration as well as because of the hypoxia secondary to the advanced lung disease. So coming to the first case, I have kept 4 cases and we'll try to finish off in the 38 minutes that are given to us. So this is a case number 1, that is a 7-year-old girl. She is second by birth order, came with complaints of cough for last 2 months, more at night and while playing. Most of the times it is wet type of cough and she is not able to expectorate it, and there is no associated fever, weight loss, loss of appetite or breathlessness. Multiple courses of nebulizations and antibiotic twice with some relief. She's been started on ICS plus LABA combination for last 3 weeks, but no change in the cough. RK ma'am, Rashmi madam, is this a common scenario, the age group and this symptom?
Can we go back
Yeah.
to the slide? Yeah, so this is a pretty common scenario to see a 7-year-old girl who has been having cough for last 2 months, and it sounds like more at night while at playing. Up till now it seems it could be an uncontrolled asthma also, but the very fact that most of the time it is a wet cough makes your antenna raise that wet cough is not seen in asthma. So, and this cough is going on for more than say 8 weeks. So we there is no fever, weight loss, loss of appetite or breathlessness. So this scenario is becoming pretty common also. So this this is a
so it is
pretty
the,
common
it is the character
scenario.
of the cough that is more important than the child is able to bring out the sputum or not. So how the child, so we have to hear this cough rather than just asking the parents whether she is able to bring out the sputum or not. So we have to hear the quality, the character of the cough, that is more important than whether she is able to bring out the sputum or not. So we'll just hear the
So this is typically the wet cough, and if the child is having wet cough for no other symptoms except for wet cough, no loss of appetite, no fever, and no breathlessness, and this kind of a wet cough, well, it gives us a thought that we should think of PBB. And but of course, this child is 7 years old. The age group for a persistent bacterial bronchitis is usually less than 5 years, we say. But yeah, we have seen a lot of children 7 years old also.
So
because in any clinic, if you go and the child comes with the persistent cough, wet cough for more than 2 weeks, almost 50% of the time it would be PBB only.
Correct, madam. So age group is ideally it should be 1 to 5 years. This child is slightly older. See, this child is around 7 years. So Kaustubh, this was done outside before coming to us. Chest X-ray, CT.
Right, sir. So first of all, thank you for having me here, sir, with such learned panel. First was very obvious thing that we can see is there is right-sided hyperinflation on your X-ray. Let's just focus on the X-ray first. Not much bronchovascular markings seen, so nicely opened inflated lung. Not any parenchymal lesions, no opacities. If you correlate it with the CT as well, you can see that the bilateral lungs, it seems to be more than, they seem to be overinflated as compared to a normal lung should see on the CT. Otherwise, more or less looks normal, sir. So nothing very marked difference.
Correct. So what should be the next step, Kaustubh? So the mic is with Kaustubh.
Okay, so here we know that we are dealing with a case with wet cough, which is lasting for significant amount of time, which I'm pretty sure we have given with normal medications, cough suppressants. Your inhaled medication is not responding. As madam has rightly pointed out, that we are probably dealing with a late onset, at an advanced age, protracted bacterial bronchitis. We should also have a thought of maybe giving a fair trial of an oral antibiotic, focusing on the most commonest organisms which would cause protracted bacterial bronchitis.
So how many of you will treat this child with an antibiotic, and how many of you will do a bronchoscopy in this child to prove your diagnosis? Kaustubh. What man? Absolutely.
No, but again, we are referring to a more generalist point of view. We don't want, agreed that as sir wants to point us out that we need to have a diagnosis before treating it. A protocolized line of manage would be to have a lower airway samples to find for an organism. But in a resource limited settings in which bronchoscopy is not the most feasible option, probably you will go with an antibiotic.
No, but clinical PBB is a problem. You don't need any test purpose.
Agreed, sir. Agreed.
Clinical microbiological. So when you have clinical PBB, you don't need test.
Agreed. Totally agreed.
Totally agreed. So where the child lands up, okay, that decides probably. So it's not that we are doing scopies, means we are doing scopies right, left, center, but still we did in this child.
So as you can see that there's a lot of thick mucoid secretions. The vision is not that great because probably the secretions are clouding the camera.
Yes, sir.
Yeah, now we are in the left mainstem bronchus, in which you can see that there is frank mucoid streak of secretions.
That's it, sir. That's it. That's it. Don't let's just substitute.
So this is the positive side of having a bronchoscopy done. We know what we are dealing with probably early. We knew that this was infective to begin with probably, but again now that we have a microbiological diagnosis, we'll be more confident in prescribing antibiotics.
Okay. So the BAL showed neutrophilic predominant, and the TB workup was negative. This was the biofire, and you can see that the biofire was showing H influenza B. Sneha madam, your comments.
I think we have discussed already the probable diagnosis here, clinical diagnosis itself. Now that we add the Haemophilus influenza B on culture has been identified, so it's also microbiological diagnosis now. So this fits into a protracted bacterial bronchitis here, and you have the definitions there as cough, wet cough persisting for 4 weeks, and in the absence of any other background diseases going on, you can safely make a clinical diagnosis of PBB, and culture will help you to take it to the next stage of microbiological diagnosis of PBB also. And if it is persisting, if more than 3 episodes are there, it is a strong, there's a strong need to evaluate the child further, because it may be the beginning of the initial, presentation of something underlying. Could be immunodeficiency or cystic fibrosis or anything. So, if it is one time treating is fine, but when you have to treat it again and again, then you need to evaluate that child.
Correct. Sir, there is always a confusion about which drug to be used, what should be the dose and what should be the duration. When you are thinking of PBB and we are labeling it as a child with a clinical PBB, suppose, so how long we should, because we have seen many times kids are getting 5 days, 7 days of antibiotic, and then there may be partial resolution in the symptoms and then they are again coming back.
The common organisms include Haemophilus influenza. Majority of them are non-typeable. Other one is followed by strep pneumoniae and then Moraxella catarrhalis. But some of our youngsters may be reading these PBO and this PBB, and then they may say that I have read that there are adenovirus, there are rhinovirus, there are other viruses. So they have been isolated, but their causal relationship with the PBB is not very clear. That's why they may be just an association rather than causal. So that is these 3 organisms, and that's why there is a reason for giving antimicrobials. And antimicrobials would be effective against these 3. The commonest would be this amoxicillin clavulanic acid, usually for 2 weeks, extended for 4 weeks. Other drugs are 2nd and 3rd generation cephalosporins if a child is allergic to amoxicillin clavulanic acid, and rarely azithromycin. What is the duration? So generally it is 2 weeks, and that's why it is in the definition also that the patient responds well to the 2 weeks of antimicrobial. There are randomized controlled trials in which extended therapy as well as 2 weeks were compared, and then it was found that the recurrence is less with the extended therapy, but it is limited studies. So that's why as of now it should be 2 weeks. If not responding, then you can extend it to 4 weeks. And standard treatment would be amoxicillin clavulanic acid, otherwise alternative.
So dose?
And doses are usual. So it would be counted from amoxicillin. So 40 to 80 milligram per kilo is fine.
So
40 to 50 milligram per kilo is fine.
Sir, when should we investigate further?
As it was discussed that we will go for a bronchoscopy, we will not go for a bronchoscopy. So if it is completely normal child having say more than 2 weeks or 4 weeks of wet cough, no other alternative diagnosis with a thorough clinical examination and history, possibly you will go for a antimicrobial. But if child is getting a recurrent problem, if there are some doubts, if there is a noisy breathing in between, in that situation you should go for a bronchoscopy. One is to look for whether there is some malacia, because that will be reason for recurrence and later on developing bronchiectasis. That will be one of the risk factors. Other thing would be that you will have an added advantage of identifying the microbial agent.
Perfect. Thank you, sir.
So I'll congratulate the team of this conference. Say over 4 decades I have seen this development of pulmonary medicine, pediatric pulmonology in India, and from the time of on one side Dr. M.D. Shah and on other side Dr. Udani, and at that time Bombay was considered to be very low in pediatric pulmonology. No one was performing bronchoscopy, and now I see that so youngsters have developed this interest, and now it is a leading pediatric pulmonology team at Bombay. Congratulations to the whole team.
Thank you, sir. So coming to the second case, this is a 7-year-old boy, third by birth order, born of third degree consanguineous marriage and with complaints of recurrent cough and cold since 1 year of age and poor weight gain noticed since 1 year of age. The child was admitted at 1 year of age with cough, cold, fever. He also had a febrile seizure at that time. 7 days of hospital stay, diagnosis was given as right upper lobe pneumonia and received IV ceftriaxone and nebulization. In between 1 to 5 years, the child had multiple OPD visits for cough, cold and fever, received multiple oral antibiotics, but still the child used to have persistently symptomatic with a wet cough. At 5.5 years of age, again was hospitalized with fever and cough for 5 days. X-ray showed again that persistent right upper lobe opacity and received amoxicillin for 5 days and O2 support for 3 days. Again 6.5 years, the child was admitted with cough, fever, diffuse lung infiltrates everywhere and then ceftriaxone and discharge after 3 days. Sir, your comment, sir.
Yeah, as you can see, this child, 6.5-year-old,
So
but
this is the first X-ray, sir.
having a recurrent problem since age of 1 year, and there is a persistent right upper lobe collapse because the horizontal fissure is going up, and there is some involvement in the right lower lobe, as you can see here.
Yes,
And then subsequently, in the child is improving with some antimicrobial, some other supportive care, but not completely normal. And now child is having a diffuse infiltrates all over, more on the right side in the last X-ray. It suggests that this type of problem either may happen if there is a persistent collapse, then it is a airway clearance problem, mucociliary clearance problem. Other is whether it is a repeated aspiration from the first year of life. And of course, then you will think of airway clearance problem would include these two, PCD and CF. And if there is a repeated aspirations, then it would be right upper lobe and more on the right side. So, and there is a significant problem that he is requiring repeated hospitalization and he is improving with antimicrobial. So whether there are some other associated problem in form of a immune deficiency. These are the 3 things which you will consider, and then further examination and history, like whether he is getting a repeated infection in the other part of the body and whether there is any other issue. Because in the last X-ray, you can see, last X-ray just show the, so you can see that even there is a retrocardiac shadow which has appeared.
Correct, sir. So here I think. Here, right, sir?
Ah, yes, sir.
Yes, right. Yeah.
Left low.
Left lower lobe.
Correct. So on examination, this child is 7 years, 7 kilos, 85 centimeters, severely undernourished, grade 2 clubbing, and saturation is 94%. There's chest wall deformity and there are bilateral coarse crepitations. Kaustup.
Right. So sir has very rightly pointed out that there is something which is ongoing chronically. So what has started at 1 year of age, or probably even at birth, I would say, since even before that, all these recurrent episodes, first you have to differentiate whether it is recurrent pneumonia or a persistent problem. So whether this child is just getting better initially just by giving medications on between and then having these issues again, or this is an ongoing thing, it's a persistent thing. Now a 7-year-old child with 7 kg is severe failure to thrive. Also, height is also faltered. There is signs of chronic hypoxemia in form of clubbing. Coarse crepitation, so there is some alveolar involvement to begin with. If you go on the X-rays, only the first X-ray probably showed right upper lobe collapse. From the second X-ray itself, there were left retrocardiac air bronchograms. So there has been involvement of the left lower lobe since initial times only, not only at 6 years of life, but even before that. So having known this thing, I would definitely want to know about feeding history, since this child is already put on NG feed here. That is number 1. Number 2, how has this child been in the interfebrile, or when this child was this child even relatively well any time during this course?
Never been.
Yeah, so there is something which is, again, now, if the child has never been well, I will also think about some anatomical malformations. If this child has had recurrent aspiration secondary to maybe some aerodigestive tract communication, most commonly being an H-type fistula, as Sir has pointed out, it could be some airway clearance disease, which in very severe form, like CF or PCD, or even some significant forms of immunodeficiencies because of which this child is falling ill again and again.
Perfect. So this child was from Adivasi community. They were referred to us from Palghar. And we won't say neglected, but definitely appropriate investigations and care was not given to this child till the child became 7.5 years. So this child was brought to Wadia through a foundation for further care. So this was the X-ray on admission in Wadia. So you can see that the child is having right-sided multiple infiltrates, and the left side you can see there are significant bronchiectasis. Left lower lobe is already, gone. So Sneha madam, so this child was initially worked up like this. Hemoglobin was around 9, counts were 12 to 14,000, and TB workup, gastric lavage was negative, and nothing that we could found on the initial basic lab investigations. So what should we do next time?
Yeah. So TB, you have already done the test. This is extreme form.
Will TB go on for like this for so many years?
It's not a TB definitely, but that is one of the tests you will do upfront because that's the easiest to do, and it has to be out of the way before we go on to other things.
Because in a child who's got a chronic lung disease, high chances that the child may develop something called as a NTM and all. Okay, so a lung which is already grossly. Yeah, everything. So it's not like it cannot be a TB. That's what I'm saying. It can be a still TB in a child who is having an underlying chronic lung disease.
So, like Dr. Kabra has already discussed, we'll do some of the non-invasive tests first before going into any further invasive tests. So, immunodeficiency, if it's not been done already, it has to be done, including HIV and other immunoglobulin levels and other immunodeficiency workup has to be done. Then history is very important here because if there has been a lot of obstructive symptoms, sometimes post-infectious bronchiolitis obliterans, they're well till 1 year or at a point, and then they develop a severe infection, and after that they are never well, with lot of obstructive symptoms rather than purulent symptoms. So the history that, whereas here you have shown X-rays more, I think it is more of purulent, so it may be less likely there. So that is also one more thing I'll consider in a similar case. At maybe radiological investigations, if feeding history, if there is any significant points there, swallow study, barium swallow, etc. can be done at this point.
So this was the CT that was done. Any comments on the CT, madam? So this is the mediastinal window, and then there is a lung window as well.
So can we go back to the X-ray? I would comment on the X-ray first. Yeah. So this X-ray definitely has a wide mediastinum. And there is no gas, stomach gas over here in this X-ray.
What you said, wide mediastinum?
Yeah, mediastinum looks wider and there is no stomach gas. This was one comment that I just wanted to make on X-ray. And then can we go back to the CT? Yeah, so in CT we see the cuts are much below, the trachea is divided, it has started below that. So we can see the right and left main, this is the mediastinal window. The vessels look all right, thymus shadow is not visible, this child is old enough not to have had thymus. And I can see from here, yeah, we can see.
Anybody from audience?
A little
pulmonary artery is dilated. Madam, you must be knowing the answer, but anything else? Pulmonary artery is dilated. Anything else? What does that tell? It probably tells you that there is some pulmonary artery hypertension. But is that the pathology? Honeycombing, okay. Anything that is diagnostic? Yes, madam.
So there is esophageal dilatation. So we can see a dilated esophagus.
What you see in esophagus is the air fluid level. Can you see in the esophagus?
And we can also see in the lowest cut, the gastrojejunal junction, there is swelling of the mucosa, the second last. Yeah, this here. So this is a gastrojejunal junction, and we can see the swelling over here. So this is esophageal dilatation. So
this was a child with achalasia cardia, with recurrent aspiration, with bronchiectasis. Okay.
Okay, so this case highlights that there is a different lobes involved, upper as well as lower, say left lower as well as right upper. If it is occurring in different lobes, there are three differentials. One is airway clearance problem like CF. Other one is whether it is a repeated aspiration or primary immune deficiency. And if you find air fluid level in the mediastinum in CT or X-ray, then it is a very severe problem if there is no malformation. If it is dilated esophagus, it's okay, otherwise mediastinitis is a fatal disease. So if anyone sees this thing that there is a air fluid level, and those who are pursuing pediatric pulmonology, you may be seeing some patients who had a TF, tracheoesophageal fistula, and gastric pull-up has been done. And then suddenly you see that there is a air fluid level and child is walking around. That suggests that it is not a mediastinitis, it is in the gastric pull-up.
Thank you.
So the X-ray also gave the clues. There was no stomach gas and the mediastinum was widened. That's why I pointed towards this. See, this is where you pick up
some clues, right? Perfect. Okay. So we have just 13 minutes left. 2 more cases. We'll go a little fast. This is a Prachi. She's 13 years and she's come with complaints of recurrent LRTI since 3 months of age. And there is history of NICU stay for 7 days and required O2 support, not ventilated. Has been hospitalized 7 to 8 times and AKT received twice. Rashmi madam. So this child is possibly some form of long-term lung disease. 13 years, multiple hospitalizations, NICU stay. Is there anything that in NICU period, that 1 month of age, till 1 month, anything that we should ask to the parents that may lead to some clinical clues, diagnosis?
Yeah, looking at the history, it definitely is sounds like a suppurative lung disease itself. And the history, neonatal history may give the clue. So at the neonatal time, if the child had respiratory distress occurring soon after birth, whether the child was ever hospitalized in NICU at the time of birth, whether the child had any delayed passage of meconium during after birth, or the child had symptoms chronic or suggestive of some aspiration in the neonatal period. These are the things which one should definitely ask in the history of a chronic lung disease.
Perfect. So preterm versus full term. So
in a full term child.
Okay. So on examination, the child was okay, vitally stable, saturation was 94%, grade 3 clubbing was there, no polyps were there, and chest respiratory system examination, the chest was depressed on the right side, airity decrease and bilateral crepitations were there. So question to Madam, Sneha Madam. So this Picard scoring is there. So is it really useful? Should we follow? Should we not follow? Should we just throw it away?
So it's a clinical scoring system which tells you when to suspect primary ciliary dyskinesia. So the starting point is a child who has a wet cough. In that situation, asking all these questions with pertaining to the neonatal period, like Madam mentioned now, and situs inversus, cardiac anomalies, ear perineal rhinitis, ear discharge, etc. There are scores for points for each of this, and you can have a total score of 14 altogether. So they say above 5, you start thinking of PCD, and when it is above 8 or 10, it is 90% probability of having PCD. So this was a score more followed in the European side. But this is not something to strictly adhere to, because you can have a very low Picard score and still have PCD. But having said that, knowing these features, if you learn about the score, you will, this is a checklist to start with. So for that, in that aspect, it is useful, but that is not something to be just strictly adhered to and say if it is negative, then I'm not going to investigate for PCD.
We still use this scoring because we have seen this even cardiologists with the patient, with them they are following the patients. They are having situs inversus, they are having conotrachal anomalies, and still they are not sending us for further investigation whether this child is having some underlying PCD or not, along with lung diseases. So what I feel, whenever a child is there of some form of laterality defects, okay, at least some opinion, or at least something, some should be recorded, a PICOD or score, or something should be written. This child may require a further workup if the child develops respiratory symptoms. Negative does not rule out. Perfect.
We have a large cohort of PCD now, almost I think close to 40 patients, and we have 19 patients we are still awaiting genetic reports. So the thing is that negative does not rule it out, and I feel the phenotype of PCD is very variable. So we have to keep a very high index of suspicion. Diagnostic tests also are not, everything is not hunky and dory, because you have to depend on so many tests to diagnose it, and it's not easy to diagnose it. So I think this is a disease which which I feel will have pick up more and more with times to come if you are more alert. Secondly, if many times they say just wet cough in infancy. It's not necessarily infancy. I would say in early childhood. So I would extend that definition. I would expect Dr. Kabra to give some comments on it.
So you are right that absence of these things doesn't rule out, and that's why it has not picked up very much in the outside the Europe, because it was started in Southampton and they are using it, but it may not be a very good tool for screening.
So this was the X-ray. As you can see, the right lung is almost completely destructed, and basic workup like HIV was negative, sweat test was negative, immunological workup was negative. What should be the next plan here? Anybody can, like Kabra sir, you can.
So it's very clear that there is a problem since neonatal period, wet cough persisting. So it becomes one of the primary suspicion of primary ciliary dyskinesia. And now the concern is that there is no single test which can give you 100% result of sensitivity and specificity. So there are 4 types of tests, 2 screening and 2 confirmatory tests. Screening is low nasal NO. Second thing is this high-speed video microscopy, in which you will identify the ciliary beat frequency and ciliary beat pattern. And then these 2, transmission electron microscopy and genetics. And immunofluorescence, in which ciliary protein is being seen. So these nasal nitric oxide and high-speed video microscopy, they are screening test, and confirmatory test is if you are able to identify 2 disease-causing pathogenic mutation. Another one is if you are able to identify abnormality in the transmission electron microscopy. So this is the problem. So that's why here, depending on your availability, you can go for one is genetic, because even if genetic test is negative, you may not rule out primary ciliary dyskinesia, because sensitivity is just 70%. So there are 2 different algorithms if you are before Atlantic and after Atlantic. So they are different this thing. Here we have to have our own protocol, and that will include whatever tests are available to us, including high-speed video microscopy, that is a low cost. Along with that, if you are able to do a good this thing, nasal NO, if they are abnormal, may go for these genetic test or electron microscopy. Because it is very difficult even to.
So it depends on the availability. In Mumbai, we have nasal nitric oxide, we have high-speed video microscopy as a screening tools. So in SRCC it is available. So if anything is of that sort of is there, it thought of having a PCD, screening test can be used, and then if it is required, we can set it for genetics further. Okay, so depending on what is available at your center or your city, what is the basic management of such kids? Now PCD, the diagnosis is PCD in this child. What is the basic management? What should we do in this such cases?
So mainly it will be a 3-pronged approach, sir. First is airway clearance, second is avoidance of infections, and third is nutrition. So since these kids have significant, the chronicity of this disease has been since birth, these kids are severely failing to thrive. So nutrition is probably the topmost thing of priority. In here, the problem is with stagnation of your secretions in all your tubular structures, because your ciliaries are not, the cilia are not able to move all the secretions from proximal to, from distal to your proximal ends. So there are various ways in which you could enhance this airway clearance technique. They could be as simple as active breath cycles. It could be using something like an a cappella, something like using a vibratory chest. You get chest guards. To further, there could be even when this child is admitted having significant collapses, could be used percussive ways, some ambulatory methods. So multiple ways in which you could make sure that all the distally clogged secretions could be blocked, could be brought proximally, so that either it's expelled out or excreted out. Vaccination plays a major role, because here, as we know that these kids are prone to significant infections recurrently, make sure that you prevent these easily vaccine preventable diseases to make sure that they don't fall ill. And that's all about it.
So one question to sir. Sir, what are these inspiratory and expiratory physiotherapy devices, and when should we use, which condition we should use expiratory and which condition we should use inspiratory devices? Can we use this device in this girl?
First and foremost is that we have to encourage our physiotherapists to be good in chest physiotherapy. Most of the physiotherapists are good in doing these cerebral palsy and others like rheumatology, but they are not very good in chest physiotherapy. So for that, pulmonologist has to be guide and leader. So explain it, and till we learn ourselves, we may not be able to provide a good chest physiotherapy. Anyone who is taking care of a chronic suppurative lung disease has to learn chest physiotherapy. Now comes this whether positive pressure or this spirometry. So if there is a lot of secretions inside the airway, then positive pressure would be helpful, and that will include a cappella, flutter, and PEP. If the child is recovering from something like a pleural effusion or some surgery, in that case this spirometry may be useful. If you do not have this positive pressure, then you can use the spirometer to some extent by providing a positive pressure. But positive pressure would be, you are bringing this your neutral point at the from the peripheral part to the proximal part, so that the secretions move up and then child is able to cough it out or swallows it.
So this device, I have tried using it ulta.
So
when you make it ulta and you try to blow it, it becomes an expiratory device. Okay, and when you take it like normally and with you inhale it or inspire it, it becomes an inspiratory device. Cheaper, 300, 400 rupees. This is 5,000, 6,000 rupees.
So there are multiple ways of doing some innovation. Even your soap bubble, put a tube and then increase the centimeters from 10 centimeter to 12 to 16 centimeter, and that would be fun for the child. But it needs to be consistent, and you should be very confident in training the parents.
But that will not give vibration.
No. So there are PEP devices which are oscillating and which are non-oscillating. So here there are no vibrations. You can't compare. That is 6,000 and this is 200 rupees. Yes, madam. Please go ahead. Please.
So with the PCD, one
last case, and this case is very important because we have got two experts on this case. Please. So we have to move fast.
Just with the PCD, another thing to teach the child is to cough effectively, because that doesn't take any technique, any money. Scheduled coughing. Once they are in school, they have to go to the toilet or somewhere and cough it out. Every few hours they have to cough and clear. So that's a simple thing which you train them to do. It's very, very effective.
So last case, this is a 3-year-old child. 5 minutes please. Born of non-consanguineous marriage, no NICU stay, well till 1 year of age. The child is coughing, no expectoration, but the parents feel that is a wet cough. Child has been breathless occasionally and is hospitalized also. Fever is there and received multiple nebulization outside and no relief. Admitted 4 to 5 times, twice PICU, once ventilated, post-ventilation developed subglottic stenosis, managed well with the balloon dilatation, and there is no history of any oily or greasy stool, no history of TB contact. This child is 3 years, 15 kilos, which is relatively good. 94 centimeters, developmentally normal, air entry is equal, bilateral wheeze crepitations, no clubbing, normal situs. Child started on MDI budesonide, 100 microgram BD, last 1 year, still got hospitalized twice after that. This is the X-ray, Kaustubh.
Keeping it short, there is right middle lobe collapse consolidation, which is almost causing cell-outing sign. You're not able to see the right heart border. Rest all looks fine.
Is the X-ray hyperinflated?
It is hyperinflated because you can see that the right dome of diaphragm is at the level with the left dome of diaphragm. So there is some amount of hyperinflation with the predominant right middle lobe involvement. And you can, if you dig deeper, you could also see some mild circular honeycombing, very early signs of honeycombing appearances just on this film, sir. The right heart border I'm seeing, sir. Partial.
It's
okay,
not
partial.
completely obscured.
Yeah, partial. Yeah.
But the pathology is definitely right middle lobe. Okay. So coming to Rashmi madam, these are some investigations which are done at 1 year of age.
Okay. Yeah, so the pH is alkalosis, and I can't read the numbers. Can you read out the numbers?
The pH is 7.66 and
so it's alkalosis.
bicarb is 32. No, bicarb is 38.
38.
Yeah.
So, and what is PO2? PaCO2. PaCO2, what is PaCO2?
One second, PaCO2 is 34.
Yeah, so it is respiratory and metabolic both alkalosis.
This is not a blood gas, this is a venous blood gas, this is not an arterial blood gas.
Okay.
Okay. This is the VBG.
Right. So, there is hyponatremia, hypokalemia, hypochloremia, and hypocalcemia. So all these point towards pseudo-Bartter syndrome. Looks like we have to do a urinary sodium. Yeah, so that is what I'm saying. It looks like pseudo-Bartter, which closely mimics the Bartter syndrome, but we have to do the urine analysis to rule out.
Sometimes I feel this Bartter, pseudo-Bartter, the patients land up with a nephrologist. Okay, nothing against nephrologist. Okay, but I feel CF is more common than Bartters in any Bartters. Okay, so all these Bartters, when you label them as Bartters, please investigate them for a CF before you label them as Bartters. They are not Bartters, they are pseudo-Bartters, and they are probably CFs. The bronchoscopy was done, which was showing Pseudomonas. Madam, your comments here.
About the bronchoscopy?
No, about the organism.
Okay, so Pseudomonas is a signature organism for cystic fibrosis. So with that pseudo-Bartter, that thing at 1 year of age, I think this should have been caught then and there. We shouldn't, that we've lost plenty of time.
What is the point here is the child was having symptoms from 1 year of age. There is 3 years. Pseudomonas is there. Recurrent respiratory infection is there. But the child is 15 kilos for 3 years, growing well. Still, will you still consider cystic fibrosis in this child? How many of you will consider? Not the pulmonologist. Sir ने बोला तो बोला. ठीक है. So sweat chloride was 68 and diagnosis of cystic fibrosis. Madam, what are the signature pathogens when they are there, either in the sputum or a ball? You should start thinking of cystic fibrosis.
So if you do cultures in very young infants, it will usually be Staphylococcus. Pseudomonas will come at some time. The time when it comes may vary depending on and many other factors. Then you may have Genotrophomonas, Burkholderia capacia, which is a very terrible organism for children with cystic fibrosis to have.
What about NTM?
Yeah, we don't see much NTM with CF here, but in Australia and some other countries, NTM is a big problem.
We have had a case of right upper lobe pneumonia, cavity formation, thought to be 1 month old child, thought to be CCAM with infection, opened, operated, malsupervision done, culture came NTM positive. And then NTM came positive, then worked up for CF and all. Sometimes it happens that way also. So sweat test is there. Madam, why no failure to thrive in this child?
So most likely this is a pancreatic sufficient child. That's why even at 3 years there is, no GI symptoms are there and maybe a pancreatic sufficient CF.
Perfect. So what is this? What are the uncommon presentations of cystic fibrosis? When should we? So routinely we all of us know that recurrent respiratory infections are there, bronchiectasis, clubbing is investigate. But what are the uncommon presentation where you should start thinking whether this child can be still a cystic fibrosis? Sir, anybody?
So uncommon is like against your expectation. It is not uncommon. It's just that you are not expecting it. That's
perfect.
All. So. If they are pancreatic sufficient, they may just present with this, every summer, the first summer especially, the baby is born and then the next summer, the baby will come with a dehydration to somebody, and that will be usually to the junior medical officer, and they will very quickly treat and get rid of the patient, and you will never hear about that patient. But that's the first opportunity to have recognized that. So summer is coming now, it is already there, April, May. All the cystic fibrosis children in your locality will come to some hospital. And if you catch them there, you will save a life. So that's
So
not
would
uncommon.
you say, madam, a child who is coming with dehydration, metabolic alkalosis, without a history of diarrhea, we should investigate further?
Yeah.
Is it?
Yeah.
Diarrhea nahi hai, still the child is dehydrated.
Yeah.
Should we investigate?
Yes, we should. And it may not be even dehydration. It may be just fatigue, being tired. For small baby, like poor feeding, and vomiting happens because of the hyponatremia. Vomiting is not the cause of dehydration. They become hyponatremic because they lose salt through the sweat, and then they start vomiting. Just 1 or 2 vomiting and they come, and we label them as acute gastritis, gastroenteritis. So that is one, common but thought to be uncommon. Pancreatitis in pancreatic sufficient patients. They may present with recurrent pancreatitis, we must get them. Sometimes even pancreatic insufficient patients may present because of the vitamin deficiencies of ADEK. The diarrhea may not be so remarkable for us to catch it, but they may present with the K deficiency with intracranial hemorrhage. E may cause, anemia is one thing which causes it results in very young infants. But also neurological symptoms and signs may be there. So these are all, uncommon is just, it's just a
so
word.
don't think that we as pediatricians know somehow about cystic fibrosis. I'll tell you a case of azoospermia. Okay, 30-year-old, married, not able to have a family, a pediatrician's child, okay, worked up, found to have azoospermia. Further workup done, found to have vas deferens substance and found to have a cystic fibrosis. And he had been treated as a preschool wheezer. That was the only respiratory symptom. Apart from that, there were hardly any respiratory symptoms. This is an article that is published by NIRRH from Mumbai about finding of CFTR abnormalities in adults with azoospermia. Sir, coming to newborn screening and aquagenics.
IRT is one of the neonatal screening tool for identification of cystic fibrosis in neonatal period. And it should be done in the first week after birth, not from the cord blood. And it can be done on the blood taken on the filter paper, and it is associated with good sensitivity, but the specificity is low, suggesting that there may be some falsely positive cases also. So once it is found, then it should be further tested for a confirmation. So there are various protocols. One is that you repeat IRT after a week. Another one is that you go for a sweat chloride after 2 weeks of age. Third one is that you go for a genotype.
So this aquagenic wrinkling test.
Okay, so because of this thing, sweat chloride not being available in India, initially we thought that we should try to see. One of the patient mother sent a photograph that my child gets this wrinkling. Then we looked into the literature, and in 1973 it was reported that CF children has a more aquagenic wrinkling. It is something like putting a child's hand in a water, and within 3 minutes it gets a wrinkle. All of us will get it. But it has it was positive in 85% of the children, but specificity was just 58%. So that's why we thought that we should combine some tests. So if you are having a child with recurrent or persistent pneumonia, with failure to thrive, with this malabsorption, you take a history whether any sibling has died of CF or respiratory disease, sputum is positive for Pseudomonas, then if one of them is there, then you can probably make a diagnosis of CF.
So why don't you develop some clinical scoring?
That's what it has been published in Pediatric Pulmonology, published in 2019, and in Respiratory Medicine last year. So if you have a child with these 2-3 entry point, along with that there is a Pseudomonas, and there is a family history positive for a sibling died of respiratory illness, you can identify that child with a confidence of 85%. And if these things are not there, then you do a blood gas that was seen here, pseudo-Bartter syndrome, hypochloremic, hypometabolic alkalosis, aquagenic wrinkling in less than at 3 minutes, or you find that stool is positive for more than 10 fat globules per high power field. If 2 of these are there, then with a primary entry point, you can make a diagnosis between 80 to 85%.
Sir, question. If sweat test is positive, do we need genetics? Or if genetics is positive, do we need sweat test?
Yeah, genetic test is now picking up because all of us are having access to it, 15 to 20,000 rupees, and we send a blood sample and we get the report. What is the importance of a genetic test is that for some of the mutations, there are some medications. You might have heard of a Trikafta 3-drug combination which improve the quality of life of the child with CF. So that is one indication that if I identify a particular mutation for which these drugs are available. Second thing is that there is a 25% chance of recurrence of the disease. Being a pediatrician and my wife being a geneticist, so we have to keep this thing in mind that we do not miss this opportunity to investigate the child so that we can counsel the family for next pregnancy, prenatal diagnosis can be done. So these are the two indications for doing a genetic test.
Perfect, sir.
Problem comes when you have sent it, parents have paid it, and then you get a VOUS. That unlikely to be CF, VOUS variant of unknown significance. So you need some consultation with the geneticist so that they can tell you that whether it is really useful or not. If you have a child with a classical clinical phenotype, two variants are there, then you can, even if the lab has reported it as a VOUS, then you can go for a translational test in form of a sweat test, and that suggests that there is a definitely CFTR functional abnormality.
Perfect, sir. Thank you, sir. So, timely treatment diagnosis can lead to significant improvement. So, one comment about the medications that have recently been started in India at 3 centers, CMC Vellore, Vada Children's Mumbai and AIMS New Delhi have started treatment for cystic fibrosis with cystic fibrosis transmembrane regulator protein modulators. These are the drugs which are available free of cost. They have to have certain criteria to start those. Like for us, the criteria is above 6 years and genetic mutation which is treatable or eligible for that medication. Okay, so if that is there, then we can start these patients, and there is a significant improvement within 6 months of starting the treatment for all those who are eligible for the treatment. So coming to the conclusion, mainly 4 suppurative lung diseases: protract PBB, bronchiectasis, lung abscess, and empyemothoracis. Last 2 I have not discussed here because we have had excellent experts on cystic fibrosis, so I wanted to include that case of cystic fibrosis here. Wherever there is suppuration in the body, as I said, it needs drainage and it needs antibiotics. Thank you so much.
Send your patients with CF to him.
So just one question, my personal question, like suppose if a patient has a positive sweat test and a negative genetics, or patient has a positive genetics and a negative sweat test, what should we do? Because one case, is it?
So send the patient to the post-check medication which is providing.
Okay.
Per month. And it is a humanitarian ground, he is getting diabetes from birthday. And his patients are improving significantly.
Sir, one more. Thank you so much for such a detailed, wonderful discussion on CF and other CSLD. I request the panelists to be present near the stage. Sir, I request Rawat sir to felicitate our panelists and the moderator, sir.
Wonderful presentation.
I request sir to give for Sneha Varki, ma'am.
Thank you, ma'am.
And that's all. So you have नहीं सर को दिए नहीं
आप मैडम को दीजिए
नहीं सर मैम को काबरा सर थैंक यू
सर एक साथ में फोटो सर Dr. Jagdish is also there in the photo.
हाँ सर. Thank you so much. Next, we have a very important discussion. It is on the upcoming RSV vaccine. Dr. Jagdish Goyal sir from AIIMS Jodhpur is going to highlight when, where and how to give the vaccine. Is it indicated in our current scenario? I invite Dr. Jagdish Goyal sir. Welcome you, sir.
Good afternoon, everyone. At the onset, I am thankful to organizer for inviting me for this talk, and I feel honored and humbled to speak in front of my mentor and teacher, Dr. S.K. Kavra sir. So in next 20 minutes or so, I will be discussing about nirsevimab for RSV, and I will discuss about the 4 Ws. So I do not have any conflict of interest for this presentation. So coming to a clinical case, this is a 5-month-old child. Just a minute. Okay, this is a 5-month-old infant presented with fever for 3 days, cough for 2 days, fast breathing and poor intake for 1 day. There was family history of upper respiratory tract infection. Child was irritable, sick looking, temperature of 102 degree Fahrenheit. Child was having tachycardia, tachypnea, SpO2 is 88%. There was intercostal subcostal retraction, hepatomegaly, and respiratory system examination. There were bilateral crepitations and wheeze, and this was the X-ray. So what is your diagnosis? Okay, bronchiolitis. So working diagnosis was acute bronchiolitis. Child was started on HFNC support, 3% nebulization, 3% saline nebulization. After 2 days of PICU stay, child worsened and shifted to NIV. Investigation CRP was 6 and TLC was normal, and respiratory panel was sent and RSV was found to be positive. So this was the scenario. So parents asked, could this have been prevented? So key question is, initially we were having only palmizumab, which was means restricted to only high risk baby, and there was limited accessibility. And now after the introduction of nirsevimab, which is long acting monoclonal antibody, and it single dose protection for RSV season and potential population based prevention. So I would try to answer 4 questions: who, when, why, and at what cost. So why nirsevimab matter for RSV? So as you all know, RSV is a leading cause of bronchiolitis in infants and major cause of hospitalization in children less than 1 year. It leads to significant PICU admission. There are seasonal outbreak stay in pediatric ward, and it leads to high healthcare utilization. This was a study which was published in Lancet in 2020. They used some modeling kind of method, and they estimated the prevalence of RSV, and they reported that around 33 million infection occur annually by their modeling method, and 3 million hospitalization worldwide, and 1 lakh death in children less than 5 years, and majority of death occur in lower middle income country, and infant less than 6 months are most vulnerable group. This was the study which we done under the guidance of Professor Kavra sir. This was a multicentric study. We look at the feasibility of establishing acute respiratory tract infection ARI unit. So 5 centers: AIIMS Delhi, AIIMS Jodhpur, AIIMS Bhubaneswar, CMC Vellore, SKIMS Srinagar, and Jamnagar Medical College were involved. So we screened the children who presented to OPD with WHO criteria for ARI, and those who require admission we admitted, and there were around 13,000 children were screened, and 350 children required admission, and out of which 7 children died. And when we investigated the cause of the death of the children, those children who fulfilled the WHO ARI criteria of pneumonia, so they were admitted. And when we investigated the cause of death, so you can see the most of the children were died due to bronchiolitis or viral pneumonia. Okay, so in view of financial constraint, we were not able to send this viral panel for all children because it was not permitted in project. But we assumed that all cases were due to, might be due to RSV virus. So this was a study which was published in rural Maharashtra. So what they did, they included 95 villages and 6 primary health center and 3 hospitals. And they found that those children who died of lower respiratory tract infection, they sent the nasopharyngeal swab and they estimated the RSV death due to RSV infection, and they found that RSV is the major cause for LRTI mortality and highest risk in infant less than 6 months, and death mainly occur in the community because those children who died at home, they also collected the nasopharyngeal swab and sent it for RSV, and very severe LRTI mortality was around 17% and 20% LRTI death was due to RSV. So they suggested that we need prevention, which may be in form of vaccines or monoclonal antibody. This was the study which looked at the different study published in India for India in acute lower respiratory tract infection. This was a study done by International Alliance Against AIDS Vaccination, HIV vaccination. So Dr. Rakesh Lodha from AIIMS Delhi was also part of this study, and the key finding of this study was that around 12.6 million RSV ALRI cases occur in our country, and 8.5 million OPD visits and 1 million admissions and around 37,700 deaths, and majority of deaths occur in hospital. Infant less than 1 year, there are 87% of death, and they assumed that 4.4% of all under 5 mortality in India may be due to RSV because they use some modeling, Monte Carlo simulation. I am not going into the detail of this statistics. So they also suggested that there is urgent need for surveillance and prevention. So what are the gaps? We all know that palmizumab requires monthly injection. There was high cost which limits its widespread use, and it restricted to high risk infants, and there was limited accessibility, and majority of infant remains unprotected. So what is nirsevimab? Nirsevimab is basically a long-acting monoclonal antibody, and it targets, so this is the RSV virus which attached to the respiratory epithelium, and there is single-stranded RNA which goes transcription and down-regulate type 1 and type 3 interferon and upregulate interferon 8 and tumor necrosis factor alpha, which is pro-inflammatory. So this nirsevimab bind here, AP protein. So this is nirsevimab, it is binding here and it blocking the fusion of RSV virus to the respiratory epithelium. So it provides passive immunization and it is designed for seasonal protection. Now key advantage, we need only single intramuscular injection and protection lasts for 5 months. And it covers entire RSV season, and it is a simplified prophylactic strategy and potential for population level use. Now there were 2 trials in pre-license era because this drug was developed by AstraZeneca and marketed by Sanofi. In India it is marketed by Dr. Reddy's laboratory. So there were 2 major trials. One was Griffin trial which was published in NEJM in 2020. So in this trial they included preterm infant 29 weeks up to 34 weeks, 6 days. So they used 2 arms. In one arm they used nirsevimab and control group they used matched placebo, and their primary outcome was medically attended RSV associated lower respiratory tract infection, and secondary outcome was hospitalization for RSV associated lower respiratory tract infection, and duration of study was 150 days. And primary endpoint medically attended RSV was significantly lower in nirsevimab group. You can see there was 71% relative reduction in primary outcome, and also it was hospitalization for RSV was also significantly decreased with 78.4% relative reduction. And they also look at the time to event analysis, which will look through Kaplan-Meier analysis. This is a time to event analysis which shows proportion event free over time, and if higher curve it means better outcome, and if hazard ratio is less than 1 it means there is reduced risk, and it is adjusted for age and hemisphere. So you can see for nirsevimab curve is higher, and this hazard ratio was less than 1. It was significantly low for both the outcome. So time to event analysis also suggested that nirsevimab was highly effective. Now, second trial was Melody trial, which was done in late preterm, more than 35 weeks, and term infant. Again, they were divided into two groups. Intervention arm received nirsevimab, and control arm received matched placebo. Outcome were same: medically attended RSV and hospitalization. They again found that this nirsevimab has significant efficacy of around 74%, and secondary endpoint hospitalization also significantly reduced with nirsevimab, and time to event analysis also suggested reduced hazard ratio with use of nirsevimab. And when they look at the adverse event, they found that adverse events were similar between both the groups. So now coming to real world experience, so it was licensed in US, and then there are two landmark studies which I would like to quote. There are many studies, but these two studies which I want to quote. One is published in JAMA. So in this study, what they did, this is a test negative case control study. They recruited around 3,000 children from Yale Hospital in US from 2023 to 2024. And those children who received immunization or those who didn't receive this nirsevimab injection, so outcome were primary medically attended RSV infection, and secondary outcome was severe RSV disease and all cause lower respiratory tract infection and all cause LRTI associated hospitalization. And they found that all the parameters, all the outcomes were significantly reduced in nirsevimab group as compared to those who didn't receive nirsevimab. This was the study which was published last year. What they did, they looked at the different studies which were published, and they did systematic review and meta-analysis, and they included infant less than 24 months, but there were primary focus in children of less than 12 months, and they included 32 studies, and they did the pool real world effectiveness, and they found that nirsevimab prevents hospitalization in around 83%, ICU admission in 81%, and LRTI incidence in 75% of patients. So now second question comes, who should receive nirsevimab? So initial ACPIP recommendation was high risk infant. These were historically derived from palmizumab. Then comes the concept of universal protection, because we have seen that this RSV infection is common in healthy term infants. So most severe RSV occur in healthy infants, and many hospitalized infants are term baby, and prevention should expand beyond the high risk group. So guidance evolved from CDC and American Academy of Pediatrics. So now latest recommendation, revised recommendation is all infant less than 8 months born during or entering RSV season, because there is maternal RSV vaccine is also available. Maternal pre-F vaccine which was developed by GSK is also available in US. So their maternal vaccination is in process. So if they have not received maternal vaccination, then they should receive this nirsevimab. I think maternal vaccine is still not available in our country. And second indication in high risk group, those who are having 8 to 9 months, only if they increased risk of severe RSV disease entering their second RSV season. When should we give nirsevimab? This is again third question. So we should administer before RSV season. If born during season, give at birth or discharge. Protection lasts for around 5 months. Align with regional epidemiology and ensure coverage during the peak season. Second RSV season, consider prophylaxis only in high risk infants, those who are having prematurity, chronic lung disease, congenital heart disease, or severe immunodeficient. Now coming to implementation in India, what are the challenges? So there are regional variation in RSV seasonality. Okay, so we are having different weather in north and west, south and east. So there are different RSV seasonality. We have limited surveillance data. Those studies which I have shown you, they were the model which have projected, but we don't have real-time data. Cost consideration. Okay, cost is significantly high. Integration with routine visit, because we need to add another visit, so we need to integrate, and policy decision is still evolving. So now coming last question is at what cost nirsevimab should be given. So currently in India it is marketed by Dr. Reddy's laboratory. So we are having with the brand name of Beyfortus. So it is available in 2 strength, 100 milligram and 50 milligram, 0.5 ml and 1 ml. In less than 5 kg, you are supposed to give 50 milligram intravenous, and more than 5 kg, 100 milligram. And in high risk infant, you need to give, in second year, you need to give 200 milligram, timing before or early RSV season, and duration of protection last 5 months. And currently, MRP is 37,000. And both for 0.5 milligram and 1 milligram cost is same. Yeah. Now, in India, price is, I think, the main barrier. Affordability is a major concern in LMIC, and there might be budget impact if we include RSV, and we need cost-effective evaluation. But on the other side, we see the cost versus hospitalization, it reduced hospital admission, reduced PICU admission, lower oxygen and ventilation use, less parental stress, and reduced economic burden. So cost effectiveness, RSV hospitalization cost around 20,000 to 80,000. Maybe in Mumbai it might be more, and maybe in Jodhpur it may be less, but it depends on city to city, but average cost is around 20,000 to 80,000. PICU care significantly high. Indirect cost in travel and parental work close. So initially what we can do, we can target high risk infants initially, and universal prophylaxis if cost of this nirsevimab decreases. So future maternal RSV vaccination, which might be incorporated with antenatal care, long-acting monoclonal antibody. There is one, this MSD is going to develop clostridimab, which is single injection but irrespective of weight. Okay, so there are few trials is going on. So soon we would be having result. Then combination prevention strategy might be best. We can give vaccination to mothers as well as the high risk infant, particularly we can give RSV vaccination, and those who didn't receive this vaccination, definitely we may consider, if cost decreases, this nirsevimab. And then improved surveillance. We need surveillance data and integration into the immunization program. So to conclude, RSV is a major cause of infant hospitalization. Nirsevimab provides single dose seasonal protection, expand prevention because beyond high risk infants, and implementation depends on cost and policy, and pediatrician will guide further adoption, particularly in national program or immunization program. So the closing thought, parents often ask, could RSV have been prevented? And nirsevimab may change the answer. Prevention may be the best strategy, but wise implementation is the key. So with this, I end my thought. Thank you very much. Yes. No, 5 months only. 5. No. The study which I have quoted, they have shown the effectiveness, and there is YTF mutation through this nirsevimab has been developed. So they showed maximum protection up to 5 months only.
So India could recommend pre-monsoon?
India, there are regional seasonality. Still, we don't have data. Okay, so it depends on RSV season. Might be different in Mumbai and Delhi.
India,
yeah.
It is in northern part of India. It is from October, November.
It might be. We found lot of cases of bronchiolitis.
I think in the western area, monsoon is the time when RSV peak is there. So our timing has to be based on.
Yeah. That's why I shown you. These are the ground challenges recommending in our country.
I have one doubt. What about the maternal RSV vaccine?
Yeah, maternal.
The seasonality can be overcome.
Yeah. So maternal RSV vaccine currently it is recommended by ACIP. So in US they have included it. So during antenatal care, if mother have received RSV vaccination between 32 to 36 weeks, then you are not supposed to give this nirsevimab.
That eliminates the seasonality.
Yeah, that eliminates the seasonality. So that might be the best approach. Yeah.
The mother is always there.
Yeah.
Right, from data kitna hai?
They are currently giving, I think, in the Scandinavian and
Studies has come that natural better than vaccination.
So I think combined strategy might be better in future.
You cannot do combined, but studies are definitely
And basically, you give the mother an RSV season is after 5 months. Okay, so means it doesn't prevent RSV. Okay, because ultimately vaccination doesn't provide long protection.
It's a very difficult situation if you offer this. If you don't offer also the problem the child contracts RSV, it becomes a very big problem.
Yeah.
So you have to say it also, but I don't know.
Thank
you.
Thank you so much, sir, for taking us to this difficult topic with so much of controversies, very nice, crisp and brief, also covering the future prospects. Thank you so much, sir. So next I invite Dr. Tanvi Modi, our Pediatric Pulmonology Fellow from SRCC Children's Hospital, to take the next panel discussion on curious cases and clinical conundrums. For this, I invite our eminent pediatric pulmonologist, Dr. Kabra sir, Dr. Mukesh Sanklecha sir, Nehal Shah ma'am, and Dr. Hiren Palwala sir, our radiologist. I invite Tanvi, please.
So we do. Yes, you need it more than I do. It will. This one is that? Yeah, it works. So I think the CVs were not displaying, and Kabra sir, we know and we've heard so much, learned so much, and it's amazing that there will be more to learn in spite of sitting here for the whole day. Mukesh Sanklecha sir and Nehal Shah ma'am, senior pediatricians, and Hiren sir, our SRCC pediatric radiology consultant. I am going to essentially present the same histories, but we are going to see that they're going to turn out to be different things, which explains with curious cases and clinical conundrums. As I was saying, when you listen to the histories, it's going to sound repetitive, but I assure you it's not going to be. I will skip over the theory parts that have already been covered, and the diagnosis is going to stun you. Beginning with the first case, a curious case of recurring cough. 3 years, 5-month-old male child, second by order, non-consanguineous marriage, came to us from Nashik. He had a history of fever since 7 days, abdominal pain since 3 days, cough since 3 days, difficulty in breathing since 2 days. There are history of 5 previous hospitalizations for similar complaints. The fever was 100 to 101, intermittent, 2 to 3 spikes a day. They gave paracetamol, it subsided. There was a wet cough, more at night, more on lying down, and as it progressed, it was associated with difficulty in breathing since last 2 days. It was accompanied with an abdominal pain, which was epigastric, dull aching, non-radiating, and of course aggravated on coughing. We took a detailed negative history to rule out all the things that we have discussed today. So I'm just going to go into the past history, that from the age of 2.5 years till the age of 3.5 years when he presented to us, he has had these similar episodes at an interval of 1 to 2 months. Each time started with a fever, had a dry cough, he had difficulty breathing, he was desaturating, and he had hospitalization for at least 2 days for each of these visits, requiring oxygen, and was always given initially IV and then discharged on oral antibiotics. When he finally came to us at 3.5 years, he had developed a wet cough, and at that point of time is when we noticed and the parents complained that he was not gaining weight. The birth history was he was a preterm, he was 34-weeker, 2.2 kg, he was in the NICU for 9 days for some respiratory distress. He had been given surfactant, 3 days of ventilation, but through RT feeds, he would start on breastfeeds from day of life 5. After that, in the first year of life, mother did not complain of any feeding difficulties. Dietary history, family, development, socioeconomic, and immunization was not significant. So this is the summary. So I would like to begin that just on this history. We'll begin with Mukesh. So what is your clinical suspicion?
Can you go back to the summary?
Yes.
So this is a 4-year-old child with a significant newborn history in terms of being preterm, needing surfactant, which was a justified indicator in any preterm. Weight gain is poor, but how is the height? Is he failing to thrive on both fronts?
So we'll come to that. He is, but weight is failing more than that. This is only on the history. Parents say he's not gaining.
The information we have is that the weight gain is poor and the cough, which was initially dry, has now become wet. Now we have 5 hospitalizations over the past several years. So obviously this is a congenital, chronic, recurrent pulmonary disease. Whether other systems are involved or not, you have not told me, because you mentioned abdominal pain, but we don't have more history about
there's no vomiting, there's no diarrhea,
to the abdomen.
There is no bloating, there's no regurgitation, there's no reflux, there is no jaundice.
Okay, so
there's nothing, no other history related to any other system.
Okay, so in the history we are right now focusing on a recurrent pulmonary event which is significant enough to cause failure to thrive.
Yes.
So your usual list comes in.
Yes, sir.
Whether it's a structural anomaly in the lung, whether it's a functional disorder like cystic fibrosis or a primary ciliary dyskinesia, whether it's
mucociliary, club that, yes sir.
Okay, a mucociliary, whether it's some sort of a reflux, or whether it's a primary immunodeficiency, which is causing poor immunity and hence these recurrent episodes. We need more history before we can go further. You have nicely ruled out various things. We go to the negative history. You've told us, that will come later on. We'll keep that low in the differential diagnosis. Because this is a preterm who's required surfactant with a relevant indication. If it was a full term, So now you've ruled out a cardiac disease. You told me recurrent running nose is not there, so that goes against something like a primary ciliary dyskinesia. Recurrent ear infections for a PID again, vomiting, loose motions for cystic fibrosis, feeding difficulties in choking for a reflux or a H-shaped fistula, and Cox contact. So I think I'll stop at this.
We've ruled out. Okay.
A little lower. In case none of these come, I would look at a surfactant deficiency initially if the same history was for a full-term baby who required surfactant. Here the indication is a preterm child who you expect to be surfactant deficient and who required surfactant once.
So we can keep it but low. 2 years, parents said he was fine. They didn't notice. Kabhi sardi khasi hote rehta hai, but nothing big. That is all the history we got. Sab अच्छा था. सिर्फ 2 साल के बाद ही ये सब start हुआ. Is typically what we want to hear from what parents tend to tell us.
Dr. Tanvi, also did you say that the abdominal symptoms were there at each episode in the last 1 year for 5 times? No.
No, ma'am.
Yeah.
Just the fever, dry cough, breathlessness. He was found, he was not maintaining saturation and he required O2. Not even ventilated, he was settling on ear and nasal prongs. So as Saurabh has very appropriately summed up, we have covered all the differential diagnosis from morning till now. We've covered aspirations, we've covered all the causes of chronic suppurative lung diseases, we've thought of immunodeficiency, we've thought of mucociliary. So we'll move on now. On examination, he was afebrile, tachypneic, tachycardic, not again desaturating. He was pale, but otherwise nothing else significant. There was pectus excavatum, no syndromic facies, and no other abnormality on head to toe. Answering your question, sir, on the height and weight, the height was within centiles, but there was failure to thrive. This is the weight that he came to us with. We didn't have all the weights from the old papers, but he has definitely crossed 1 centile from what we saw. But we don't know his starting, where we start plotting from. So he was classified as MAM. On examination, there was the pectus, there were significant retractions. Even though the expansion was equally bilaterally, the trachea seemed central. Auscultation, there were bilateral diffuse Krebs and Wies in all lobes on auscultation. Heart sounds normal, no murmur, CNS and normal developmental wise. no organomegaly, no abdominal findings. So adding on to the summary, from here, any additional clues that we get after examination? Nehal ma'am.
Yeah, so surprisingly, first of all, as a generalist, I'm so happy to be shielded with an expert radiologist is going to answer and my senior pediatrician is there. So anthropometry, the height percentiles are pretty good. So probably a chronicity and a disabling thing can be ruled out. We are not saying that it is out completely, but this child has thrived well as far as the height is concerned.
Yes.
The weight has faltered obviously over the events that have happened in the last 8 months, 10 months, 1 year. And as you said, this is a moderately acute malnutrition. What is surprising in the general examination is you have bilateral findings. You have a 3 or 8 month old who already has a pectus excavatum. Yes. So unless we are ruling out the most commonest cause of a pectus, which is usually familial, and you have all these connective tissue disorders and all, in this case, with bilateral findings, with significant subcostal retractants, intercostal retractants, it does speak of something which is going on to affect bilaterally the lung, a generalized pulmonary disease which has been disabling, which has been probably causing a contraction of the mass, and you're already getting a lung, pectus excavatum. In spite of all this, and yes, the child has desaturation at room air.
Yes,
so this speaks definitely of some kind of a perfusion problem as well. I mean, the oxygenation as well. And it speaks of a terminal airway to now that dry cough is becoming wet, even a parenchymal involvement.
Yes.
So this is what we can make out, that although the intervening 2 years have gone well, the child has presented at 3rd year, but is looking quite sick otherwise with all the findings that we have. Definitely. Maybe some kind of a structural congenital may go out, and we may think more of a functional congenital, which 2 years the child was fine. I mean, he didn't, I'm saying the other way around, sorry. The functional is out and maybe the structural is more in because it has preserved his height percentiles. So I think this is the way probably I would have looked at as a
beautifully summed up. Yes, sir.
We have not accounted for the pallor yet. Providing his nutrition is all right. I think his hemoglobin, how much have you said how severe is the pallor?
It was mild on examination. It was not, we are attributing it to the fact that he was chronically ill. Nothing yet acute. Kabra sir, would you like to add anything?
No, nothing. They have already discussed. Major issue is we are having a child with recurrent respiratory problem with pain abdomen and reasonably thriving well. And there is a mild pallor. So on examination you are finding pectus excavatum. Now we have to see whether it is causally related to the whole issue or is it unrelated, incidental. If there is a significant pectus excavatum, how it will affect the system. One is compression of the heart and there is a compromise of the cardiovascular system. Second thing is there may be associated other malformations in form of a say duplication cyst or others in which there may be a gastric mucosa and which is causing bleed and epigastric pain. But there is nothing significant history suggestive of any feeding issues. And third thing is whether he recovers completely, the tachypnea, tachycardia and chest syndrome, whether after treatment it recovers completely. And in that case we say that it is a repeated episodes which are getting cured with your IV antibiotics or IV therapy.
So to answer your question, initially from 2 to 3 years, the mother said he did get better completely between episodes. But between the last one and this, so in the last about 4 months, he has never been fully fine and that cough has been lingering even after completion of the antibiotic course, though there's no fever.
So we have to see if we attribute it to pectus excavatum, whether there is a functional abnormality in the airway clearance and cardiovascular system. These are the two things which needs to be evaluated further. There is no pulmonary arterial hypertension, pH clinically?
No sir, no loud P to anything.
Clinically we are looking at an ILD, this symptom is like an ILD which is appeared from 2 years onward. And
for any chronic illness which is causing hypoxia, if there is a persistent problem with intermittent exacerbation, you are reasonably sure that rule out ILD, but here it is recovering and then now lately he is having a persistent problem.
Sir, each of the illnesses you said was dry cough, specified dry cough, and each of the illnesses there was desaturation. So I would agree with Rawat sir that I would keep ILD higher because each episode made him desaturate.
Sir, also how do you take, as each of these episodes you've highlighted the dry cough? Dry cough, breathlessness and desaturating and getting better, I assume. So in between those two he's fine because he's not chronically hypoxic, he's not clubbed, he's not gone down, his height is not affected.
Not yet.
And he's getting better also. And then the last episode is wet cough.
Last maybe 6 months he has not gotten better. Before that, the episode
yeah,
before
but the
that,
cough variety. So
the
if you're
cough
going to
has gotten better according to the mother, that he's been okay after treating with the antibiotics.
So if we just discuss for the theoretical this thing that ILD above 2 years of age, then the previous causes are less likely unless it is a ABCA deficiency or protein C deficiency, which may manifest later on, or some other illness like a congenital PEP. That may be another possibility which may present with a chest deformity and this thing. Other common ILD would be if there is exposure to various allergens in the environment from age of say 2-3 years and subsequently now it is going into a chronicity.
So like a hypersensitivity, pneumonitis. Okay, so that was, so how would you like to begin investigating this? Ma'am, what would be, if I ask in Subhashi sir types, that if you have to choose the 5 investigations? Yes, so the differentials that we considered, definitely mucociliary, primary immunodeficiency, and H-type fistula where there was no apparent aspirations, but an H-type can be ruled out. It can present in about 1 to 2 years. Congenital malformations are there. We ruled out congenital heart diseases clinically, so it was not high up on our list. But we definitely, as Kabra sir rightly mentioned, we will keep the genetic disorders of surfactant metabolism as the main ILD, as Rawat sir has already pointed out. We have the pros and cons which we have discussed, and here are the labs. The CBC hemoglobin, which I said was pale, hemoglobin was 11. It was microcytic hypochromic. Total counts were 23,000, neutrophilic predominance, platelets were 3 lakhs, ESR was 33. The CRP was 77, so it was done and it was treated. The serostatus was negative, electrolytes are there. ABG had pH of 7.45, oxygen of 90, CO2 26 and bicarb of 18. We did a sweat chloride which was negative. The immunoglobulin profile was done, which was 470 and 182. It was not low or high significant enough, and immunologist reference was taken. And the DHR LSSA did not show any apparent abnormality. 2D echo was done to rule out any cause of recurrent infections, which was also normal. And now coming to the question of the hour, these are the 2 X-rays. These are the only 2 X-rays that we had. So Hiren sir, this one's over to you.
So looking at the radiographs, you can rule out so many things that there was some doubtful question of some structural malformation in the lung. So obviously on the X-ray, I am not seeing any obvious cystic lesion or any other malformation in the bilateral lungs. What I can see that the bronchovascular markings appears very prominent and thickened. And if you look at the radiograph at 2 years and 7 months, which is looking slightly better, which shows some subtle ground glass haze in bilateral lung fields. Echo has ruled out any cardiac problem. So I would say that this, as keeping with the examination, that the findings were there, bilateral crepitations and all. So that also we can secondary correlate with the X-ray finding that we have got generalized bronchovascular thickening and some subtle ground glass haze in bilateral lungs. That's the finding on X-ray. But I would like to further do investigation to narrow down differentials with the CT scan.
So the pediatrician has definitely ordered a CT scan.
So for all of you, this is a lung window in which we focus on airway and the lung parenchyma. Yeah, so you have got a lot of findings in the radiographs. If you can run again.
Yes, sir.
Yeah.
So you can tell me to pause whenever you want to.
Yeah. So the thing is that can you pause somewhere? Yeah.
The answers.
Just pause it here. Somewhere you pause it. Yeah. So for the understanding of all, what we are.
Yes, sir.
Yeah, somewhere you can pause. I just wanted to show that.
So. Yes, sir.
Yeah, so here you can see that like there are several parts of the lung. Sorry, different part of the lung parenchyma shows different attenuation. So this is the low density area, and somewhere here you can see some relatively higher density area. So this pattern we call it as a mosaic pattern, which can be seen secondary to that small airway involvement, like the pathology involving at the bronchial or terminal bronchial level. That can cause this kind of mosaic pattern. You can see peripherally there are this kind of tiny nodules and some subpleural collapse in the periphery. As we go lower down in the lower lobes, if you go. Yeah, more further lower down. More down. Yeah, more. Right. So just wanted to highlight that in the lower lobes, there were some areas of dilated bronchi which indicate some sort of bronchiectasis. And yeah, here. Stop. If you stop there, some here. Just above that area was showing some dilated air-filled bronchi, which we should not see normally. In the periphery of the lung, the airway should not be this much dilated, which indicates there's some sort of element of bronchiectasis always. And you have got predominant peripheral-based subpleural ground glassing and the subpleural atelectasis area. So it looks like some sort of diffuse generalized process which has involved the walls of the airway in the form of bronchitis, plus it has element of some sort of bronchiectasis as well. Now, if you consider as a interstitial lung disease, this will be atypical finding because usually in interstitial, unless it's an end stage, we don't expect to be bronchiectasis as a primary component. And this kind of subpleural collapse and all that can be seen in NSIP variety of interstitial lung disease, but that will be having some different presentation. So based on this thing, I would be looking for some problem which is affecting the airway, which is causing secondary bronchiectasis, in which the differential would be mucociliary disturbance related disorders like primary distillary dyskinesia, or very rarely sometimes cystic fibrosis also can be seen in this way. So that should be take from the CT scan.
Thank you, sir. Anyone? Yes, sir.
Newborn screening was done in this child, like now it is becoming more and more common.
Not routinely, sir. Very not affordable. Nashik.
Sir, also for ILD, wouldn't it be that the first episode that he desaturated, he's manifested already? There is some kind of a problem that has already happened. Is he likely to get better? And you're going to have interfebrile normal periods going on for a year?
So
even that point, that can probably...
So, ma'am, we had the same suspicion that this was better maybe as per the parents. And if we look at it retrospectively, we feel that maybe he was not completely better, and this was definitely a progressive disorder going on since the last 1 year. And the parents maybe noticed or took it seriously only when they noticed that he's not gaining weight or appetite affected, which is usually the case.
I think an APCA 3 would come with the entire varied manifestation, right, from severe to mild. And also SPC will also come in this manner. So it's possible that child is apparently okay in between, and yet he is one of these congenital surfactant deficiency kind of.
The other thing that looking at the multiple opacity at various space, I would like to see any earlier radiographs and all. Is there any fleeting opacity in between the course which could think me to rule out any congenital immunodeficiency disorder which can present with recurrent infection. That could be other thoughts. And the findings are more of a peripheral and it's involving the walls of the bronchial. So again, like the ILD will be at the lower spectrum, but I wouldn't be able to rule out completely.
Sorry, sir, interrupting.
Yeah.
Sir, because you said there is peripheral consolidation, can there be a COP kind of picture based only on CT?
COP means you are doing
Project
objective.
organizing pneumonia, sir.
So in congenital organizing pneumonia, you are saying.
COP, yeah.
So for that, we should have the previous imaging or something. On first, if you show this kind of pattern, yeah, it is possible because the organizing pneumonia has this kind of either subpleural or it can have peribronchiovascular as space consolidations or opacities. So based on that, yeah, it can be your one of the thought. Yeah.
Thank you, sir.
Yeah.
So based on the CT, this is, as sir rightly reported, this is what we were suspecting. There was a primary immunodeficiency because going by the history, there was a fibrosis, probably repeated infections, some airway anomaly, mucociliary, interstitial lung disease, keeping surfactant metabolism given the age, keeping it high up, and aspiration given the low predominance, we don't know, but we'll have to look again. H-shaped fistula is the only thing that can come like this. So the role of a bronchoscopy, Kabra sir, if you would like to elaborate.
Yes, if there is a recurrent problem, we should go for a bronchoscopy. One is to rule out any structural problem, and other thing is to take a bronchial lavage, not only for the infection, for the other things also. That one of the things which is propping up is whether it is because of the surfactant protein. 6% of the children, one is PEP, in that 100% will be positive. But in EBCA or C3, it may be 6% of the time we can find some abnormal this thing. Then you can see the type of cells and ratios, various ratios if it is possible, CD4, CD8 ratios.
As a general pediatrician, I would not refer this for a bronchoscopy yet.
Not yet. Okay, sir. Sir, what would you do next? If not a bronchoscopy, what would be your next
go
line?
back to your list of differential diagnosis.
So this was the differential diagnosis at
Now,
this point.
Where I have primary immunodeficiency, mucociliary disorders, and interstitial lung disease, I would do a genetic test in this child to hit 3 wickets with 1 ball. So I would do at least a whole exome, if not anything less. I would be able to pick up a PID. I would be able to pick up a mucociliary disorder with reasonable, because more and more they are talking about using genetics as a primary screening method for mucociliary disorders.
Yes.
And I would also pick up the surfactant metabolism problems. I would pick up APCA3 and SPC. So I would love to do less invasive from a general pediatrician's viewpoint test, knowing very well that it will take about 4 to 6 weeks to come, but the child is pretty stable. So I would do a genetic test before I went.
Just to add some points on imaging, if we look for mucociliary as a PCD, the PCD has predilection towards the middle lobe and lingula, which was relatively spare in this case. If you look at the cystic fibrosis, they have more of a upper lobe predominance, but here the findings more was in the lower lobes. So those also will come in the lower part of your differentials. Yeah.
So Mukesh, I completely
You've not
agree.
included cystic fibrosis in this list.
Not yet, sir. A PCD more than a CR.
Knowing how varied the presentations with cystic fibrosis can be.
Sir, also knowing that the CSLD session was just before mine and it would be discussed in detail, so I've also, it's definitely not cystic fibrosis, but mucociliary is there. PCD was a higher, because PCD has a higher phenotypic variability, as ma'am said, we have so many heterogeneous presentations, that was on our list for sure. So because he was referred to a pulmonologist after multiple files and papers and prescriptions of a lot of pediatricians, we did a bronchoscopy to definitely look for any airway anomalies causing chronic aspiration, and also maybe look at the bowel sample for any clues that we get. And this is what we found. So, Kabra sir, if you want to elaborate as we see, or we can watch it and we can have your comments after. I'll just covered the major airways.
There are thick secretions. Now, the person who did it, whether it was a very viscid or it was a mucoid and purulent.
It was mucoid and it was purulent, sir.
If mucoid and purulent, then you will go towards the chronic suppurative problem in form of a PCD. And if it is very thick and viscid, then you will think of CF.
Yes. So it was purulent.
And there are no other congenital malformations which you are able to see.
No.
So if it is a purulent and easily clinic, you could do it easily, suck it out, then possibly it is a chronic suppurative lung disease, bronchiectasis. One of the reason may be PCD or other causes for primary bronchiectasis.
Right, sir. So in another finding we got on this was there was significant bronchomalacia which we got on the right side. So we definitely kept that into account, that we could see a bronchomalacia on the left side also, and even some of the lower lobe and middle lobe and the lower lobe bronchi were all dilated, which was representative of the bronchiectasis that we expected to see. So bronchomalacia right more than left and purulent secretions throughout. The bile grew Pseudomonas putida, not aeruginosa, which was sensitive to C4-sulbactam. The gene expert was negative. He was started on sensitive antibiotics, given airway clearance techniques, and definitely advised to send a whole exome sequencing. We used the bile because that gave us additional clinical clues to include in the phenotype. So at what point a general pediatrician might probably, it was a less invasive method, as sir rightly said, whereas we would go an additional way to include more details about the phenotype and the findings, but the answer is definitely there that we wanted to send a whole exome. The patient sadly was lost to follow-up at this time. He returned 6 months later with again similar complaints. It was similar management. Finally, the whole exome was sent. The whole exome report was awaited. There was no significant change in any of the findings, not even the CRP. And this was the x-rays that he came with. The x-rays were 3 days apart only, at the onset of his symptoms and the day that he presented to us.
So this time, if you notice that as compared to previous radiograph, the opacities in the peribronchovascular and perihilar region, they have increased in amount as compared to previous scan. And if you look at the lower zone, right side, you can see some cystic lucencies, which has progressed as compared to the previous scan. So definitely there is progression of the findings in bilateral lungs, which are more marked. Again, that's central peribronchovascular, perihilar region, and in lower lobes also we can see some cystic changes.
So, and possibly some cardiomegaly. So we did repeat a CT. I know it was a very short interval, but the child had deteriorated. So we did want to do a CT to see what the disease progression was. So do you want to go over the findings as well?
Yeah, see, now the findings again, they are in that subpleural location, but they have increased in amount as well as severity on both lobes. Now I can see certain areas, some sort of pleural retraction, which indicates some sort of underlying starting of the fibrosis. So that also indicates some sort of interstitial involvement of the bilateral lung parenchyma. See, look at now bilateral lower lobes. And many times this bronchiectasis can develop secondary to fibrosis as a tractional bronchiectasis and secondary to infection, that what we have found previously. The findings are bilateral, almost like nearly symmetrical, more of a subpleural. Now I should start thinking that I am dealing with some sort of underlying interstitial lung disease in question. Yeah.
So that is high up on our thing. We did a bronchoscopy again to see if there was any change, if we grew any other any organisms. The bronchomalacia that was seen initially was not seen. There was still purulent secretions, and this time there was a bile AFB was positive, but the gene expert was negative, and we tried to do a transbronchial lung biopsy suspecting an ILD, which had fibrocollagenous tissue and no exudate. Sir, Kabra sir, would you start ATT for this patient?
I would say that his clinical features of whole disease spectrum is not because of TB. One. Second thing is gene expert negative and BAL AFB positive. So one is whether it is a contamination from the water and other thing. And if there is a setting, then you will think of NTM. And it should be repeated, and then you will do a speciation. But first possibility would be whether it is a contamination of your scope or your environment.
So we thought the same. We did NTM. We suspected an NTM. We started the regime till the culture was awaited. We got 6 weeks culture negative. We got an NTM culture negative. The NTM PCR we could not send. It was not available at the time. And then we stopped the NTM regime. And we got the genetics report by that time. And as it hit the nail on the head, it did turn out to be surfactant protein C. With recurrent pneumonias, it was interstitial, started with breathlessness, dry cough, hypoxia, as an ILD is expected to start. And it was the bronchiectasis secondary to the fibrosis as a traction bronchiectasis. So fact, I will skip through the theory, but one important question for Hiren sir is why didn't we see a crazy paving? It is a surfactant protein disorder. We need to see PAP. We need to see septal thickening and...
yeah, so that's what I was also surprised. Like usually we find this, especially the infantile diffuse lung disease, they have this kind of diffuse ground glass opacity and inter as well as intralobular septal thickening, which will give rise to the crazy paving. But there are certain disorders like this kind of surfactant protein C deficiency. They can have slightly different imaging appearance that probably you can show in the next slide. How are the things? So that's what I'm saying, sir. Either it is progressive fibrosis which leads to tractional bronchiolitis, or recurrent infection which is developing that can lead to.
He had recurrent infections.
Yeah.
Yes. Yes.
And I think this surfactant C is a slowly progressive
It is.
right? So you may not get that
We don't get it right at the beginning. Right, ma'am. So management-wise, as per guidelines, we started on the steroids, tapered them down, HCQ and azithromycin, and the mainstay was airway clearance technique, which was continued. He's done much better. He is gaining weight. He is gaining height. He's had only one LRTI in the last 2 years now, and he's got good weight gain. But we did a PFD on follow-up, which is, of course, showing severe restrictive lung disease, as we expected, with the chest wall deformity as well as the fibrosis. So the take-home message for pediatricians is that don't wait for so many files to accumulate. You can suspect it early, maybe send off a genetics early to confirm it and refer, because it could be a rare version. Surfactant protein C is notorious to have a very heterogeneous age of presentation out of all the other known mutations, and it has a highly variable phenotype. Early diagnosis, early institution of the therapies like hydroxychloroquine can actually help in preventing the disease progression and give better outcomes. So lung biopsy used to be considered the gold standard for diagnosis, which is now avoided. So I'm going to quickly run through the next case because the history is very similar and a lot of the points of the theory points have been discussed in just the CSLD case. He was a 1 year, 8-month-old boy who was born again, non-consanguineous marriage, brought to us with a history of wet cough and fever since 2 weeks, despite oral antibiotics. He has taken, prior to this, that was 4 weeks, sorry. He's taken 10 days of Augmentin, 10 days of Cefpodoxim, and parents give a past history of recurrent cold and dry cough every 2 to 3 weeks since 1 year of age. Each episode lasts about a week, requires bronchodilator nebulization with some relief only. He was also treated for vomiting after feeds, treated as GER at 12 months of age, but the episode resolved within a month. And now parents think that since the last 8 months, he is not gaining weight. So the main complaint is wet cough, fever again, prolonged period, and not gaining weight. I've ruled out a negative history as per all our DDs. So we're just no fever with episodes until this one. It only used to be a cold and a cough. No oily stools, no eczema rashes, no choking or coughing while feeding now since the last 6 months, no recurrent infections, no symptoms suggestive of a cardiac disease, and no family history of atopy, allergy, or any sibling deaths. The birth history, he was preterm, 30 weeks, 1.9 kg. It was LSCS in view of uteroplacental insufficiency. He also had 14 days but not ventilated. It was just for his low birth weight. And he was on O2 for 10 days in the beginning, has not received surfactant. Immunization was complete as per schedule till 18 months. Clinical impression, if we have to just bring it down to 3 DDs, Nehal ma'am, what would be your top 3?
So if I get that history, only the last episode had fever and wet cough going on for 2 weeks and you gave 2 sets of antibiotics. But since 1 year of age, this child is born 1.9, a little preterm, not requiring anything special, okay till 1 year. After 1 year starts having predominant cold and cough, dry
Always
cough.
starts with a cold and cough.
So cold and cough and no fever.
No fever.
Probably some kind of an upper airway pathology that you're looking at. And now the last episode means that there is either a progression or involvement in that time that he's come infected. So cold, and if you're looking at the upper airway, then you're probably a cold. 1 year again, atypical for a typical atopic rhinitis to come in and a dry cough to come in as episodes, main episodes coming to you again and again. So are we looking at some other case of cold coming up? So upper airway again, should we go back to your mucociliary? So I'm hesitating to say that because you can't be putting so many cases of the same. But is it really an upper airway ciliary problem and you're having a cold and then a lower airway along with it in the form of a dry cough? And now a progression is something
the thought process is exactly what we thought. Initially, because he had the prematurity history, he was just an early transient wheezer. Aspiration syndromes were ruled out because he had some history of vomiting but not specific. We kept airway malformations as a suspicion. Mucociliary, again, PCD higher than CF because of the persistent upper airway symptoms. And of course, with so many infections, an inborn error of immunity is always high up on our list. Here, again, clinically, except for the not gaining weight and the failure to thrive, overall, the general examination was normal. He was maintaining saturation. He was not even pale, not clubbed. Systemic examination just had air entry decrease with some creps on the right side, which were diffuse. And there was a little bit, there was relatively decreased air entry, but no other abnormality on examination. So this is the summary. And from here, would we call this a recurrent pneumonia? Is it a persistent pneumonia? If it's been there for 4 weeks, can we call it a PBB? Is it fitting into a PBB?
So we are just talking about this current history, I believe, when you're talking about pneumonia per se. I mean, we dissociate the initial episodes which are only cold and dry cough.
Right,
they don't come as pneumonia. So this last thing is one episode that we are talking about. So then that one episode which is not improved to 2 sets of antibiotics means there is something which is persistent. There is no way recurrence because there is no intervening period of normalcy.
Right.
So this is now that lung parenchymal localization, probably right, as you said, right lobe that you've pointed out, localization, and there is a persistent pneumonia there.
Correct. So recurrent pneumonia is at least 2 pneumonias and it has to be an asymptomatic period of clear chest x-rays. This we will use as a persistent pneumonia, but we need to show there is no improvement in symptoms and no radiographic investigation. Hiren sir, these were the x-rays when he presented at 1 year 8 months, and then we have serial x-rays coming up.
Yeah, so you have been provided, one was done at 1 year 8 months and then after 1 month. So if you see the radiographs, the first one on the left side shows that there is some sort of a mild metastatic shift was there towards the right side, which may indicate underlying volume loss. There was some airspace opacity in the right midzone and probably in the this paratracheal region also, and some sort of opacity in the left side also. There were some slightly asymmetrical changes, more in the central part as compared to peripheral part, and those findings are resolved on the follow-up imaging. That could be either infection or maybe some aspiration-related changes. Right now, what we are seeing that there is abnormal this triangular shape opacity, which is separate from the thymic shadow. You can see it is not merging with the paratracheal stripe region, so that is not part of the thymic shadow. It looks like some sort of triangular areas of collapse in the suprahilar region, and probably in the left lower zone also retrocardiac. You can see this kind of triangular areas of airspace opacity, which also probably indicates collapse. So you have got some sort of recurrent collapse in the bilateral lungs, which are resolving and again coming back. So it has to be either some central airway problem, or it can be secondary to GERD or some structural TEF kind of problem.
So we did the investigations. They were also unremarkable. This was the CT scan. So these are only films. We don't have video of the same, I'm sorry. But Sorry, I think the significant, if you can see here, we have the left side lower lobe collapse.
Yeah, in the left lower lobe, you can see that there is near complete or lobar collapse with that central air program sign going through.
Yeah. So from this, the bronchoscopy was done outside. There was normal airway anatomy, no malicias. There were purulent secretions which grew Pseudomonas aeruginosa. So I'm not going to waste time discussing, but we have right upper lobe, some left lower lobe, failure to thrive, recurrent persistent wet cough, Pseudomonas in the bulb. So definitely worked up for CF. This was the report that I wanted to discuss primarily, just in continuation to the previous session. Sweat chloride was negative. The stool elastase was normal. The genetic report was reported as likely pathogenic in spite of being heterogeneous, autosomal recessive, and by RT-PCR also. Kabra sir, if you could elaborate on this. Was it right to be labeled as CF by the treating?
No, CF is an autosomal recessively inherited disease in which two alleles should be found. Here it is a heterozygous. It found only one pathogen, which is likely pathogenic variant. In such a situation, one possibility is that it may be just incidental, that we are looking for something and we found one allele and he may be just a carrier. Another thing is that there are so many mutations, one of them may be intronic or it was missed in the exome sequencing. So in those situations, we have to do a further analysis based on what is our pre-test suspicion of CF in this child. So if there are some other associated, other supportive evidence in form of say malabsorption or there is a other electrolyte abnormality, sweat chloride was normal. In that situation, possibility is that we do not have a pretest probability of very high suspicion of CF here. If we find some alternative cause, it's fine. Otherwise, you can go for a intronic. As one is to ask the lab to check it again and look for other mutation which in the intronic region. Otherwise, you will go for a MLPA subsequently. And last possibility is that if both these, if they report 2 and sweat chloride is normal, in that situation, it may be a atypical CF in form of a less than 2% of these may have a atypical CF.
Okay.
This was a whole exome?
Yes, sir.
Okay,
This
so
was
now,
a whole exome.
Yeah, now we talk about the mixed heterozygous.
Yes.
The delta 508, though it's very common in the Western population, almost 70 to 85%, I think the Indian population delta 508 is, though it is the commonest, but the incidence is as low as 25 to 35%. So if you've done a whole exome, you have missed one of the mixed heterozygous cystic fibrosis. So what we need to do is a next generation sequencing of the entire CFTR gene to pick up any specific CFTR gene defect which will check all 27 genetic defects in the cystic fibrosis. Only then you will be sure that this is cystic fibrosis or not. But a sweat chloride being normal is strong evidence against the diagnosis.
So I'm going to skip everything which we have dealt with now. He's persistent and I'm directly going to jump to, he's had repeated episodes once a month. He comes to us till finally he came to us in December, very tachypneic, non-maintaining saturation, diffuse Krebs bilaterally. This was his X-ray again. So this was the last episode, 1 year, 10 months, and this is 2 years when he presented to us. So there was some 2 years before he presented to us. So there was some clearing in between. This time when he came, this was his X-ray. Hiren sir?
Yeah, again, I can see the same finding, the right-sided upper zone near the paratracheal area, that's opacity is there. And left retrocardiac also now, again, that triangular areas of opacity, plus some cystic changes within that location. Even you can see that in the right lower zone, retrocardiac and paracardiac area, some cystic lucencies are there which can be suspicious for developing bronchiectasis.
So we sent a whole exome for reanalysis. Sweat chloride, at parents' insistence, we repeated, it was still negative. But the bronchoscopy showed us something very interesting. The airway was grossly normal. There was no malicias. This was the right upper lobe that we can see. We can see some whitish, some granulations. We can see some militia there. It went back. Oh, some more, sorry. Some. There. We can see some whitish granulations. Here. This was the right upper lobe bronchus that we could see. I am short of time, so I would like to skip the.
We saw a lot of caseous material in the right upper lobe.
If you all can appreciate these whitish areas, everyone in the audience. Here, which is the nodular irregularities, the caseous material that is coming out. So, we collected a ball. This was, the ball also had gram-positive cocci in pairs. The gene expert MTB detected was trace. It was refi resistance indeterminate, and the culture grew Streptococcus pneumoniae. The culture was awaited. We started the treatment on first line AKT and the child was doing well. I'm going to just answer. We started steroids because it was endobronchial spread at that time, considering an endobronchial TB, and the child is currently doing well on ATT. We've tapered off and stopped steroids. He's in the continuation phase and has improved appetite, good weight gain, and the genetics re-evaluation that came is CFTR heterozygous picked up, reported as uncertain this time, but it also picked up a heterozygous mutation for PCD, which is DNAH5. So, sir, your last final comments to end this case.
As I said, we sent a report and then we get this type of, and it may be that if I send, say, NGS for, say, 100 people sitting over here, and then at least everyone will have a 8 carrier state of a various diseases, genetic diseases. So that should be interpreted with caution. Second thing is here, it was a resistance was indeterminate. In that situation, we should go for a, because we are not very sure, we decide whether there is a risk factor for drug resistance. Like if someone is in the family, he was exposed to anti-TB drugs, or whether there are any other obvious focus of infection. In those situations, we try to repeat a sample to document whether there is a drug resistance.
We didn't repeat a BAL, we did a GL, and we followed the due protocol of diagnosis.
You can do a breast or a small biopsy to see the pathology. But the child has responded well, so it suggests that whether it was a TB only. Only concern is that whether we can explain TB is incidental or whether whole disease can be explained by TB. So in such a situation, when there is a TB along with other infections, Pseudomonas and other things, so you have to think of MSMD.
Yes. So we didn't get around genetics. We want to evaluate further. And my personal doubt, what I wanted to ask, sir, is there's a double hit phenomenon which we have read about in papers. That if these two genes, though heterozygous, are found together, is there any risk of one of them causing expression of the other in that double hit phenomenon, which is reported in some papers?
Yeah, there are reports that there may be interaction between the two abnormal mutations. Whether it can be that is need to be seen and need to follow up.
You're asking for cystic fibrosis?
So for mucociliary, sir. For mucociliary.
I have.
Yes, sir.
Yeah, I have one observation.
See, that is the problem with.
Same mutation. Cystic fibrosis, same mutation. That is not uncertain significance. That is pathogenic. Heterozygous.
Heterozygous, but it's not uncertain significance.
It was second one was reported as uncertain significance.
But another genetic lab said
that particular mutation is pathogenic.
But it was autosomal recessive and heterozygous. So.
The mutation is not of uncertain.
This is the first, the mutation is. Yes, sir. So, yeah. So with that, I think that was the two cases which took us through the full spectrum of the full day. Thank you for your time. I will send it the father. Yes, sir. Put it there. Yes, sir. Thank you so much for those valuable inputs, and thank you to everyone who sat till the end also. Thank you so much.
Now I call Indu ma'am to felicitate our panelist and moderator. Hiren sir. Hiren sir. So much confusion. All the faculties and delegates for patiently waiting till almost the end of the session. So now we have the last interesting session. So from morning I have been seeing many people waiting and seeing and discussing all the radiology cases. So now we have Sonal ma'am and Hiren sir who will be discussing the radiology quiz. We have Hiren Panwala sir, who is our senior consultant pediatric radiologist. He is trained in CMC Vellore. And then we have our most dynamic Sonal ma'am, who is also a well-known pediatric radiologist. I invite both of them to take through us the answers and discussion of the radiology quiz and also to announce the winners. Over to you, ma'am.
So first, should we announce the winners and then the answers to make it more interesting, or you want to first announce the answers? Okay, we'll do that. Suspense रखेंगे ठीक है.
First of all, thank you for staying for the quiz part. How many of you participated actually?
16 have participated. 16? 16 Okay, 16 people have participated in the quiz. So congratulations to all those bold people who decided to test their knowledge. I am seeing some of the people who attended our radiology workshop yesterday. So I sincerely hope one of you are the winners, because that will be testament to the fact that you were awake and listening yesterday.
One more thing that, so we as a radiologist, we are supposed to spot the smallness of the Q in the images. So now it's your time, if you can pick up any clue and make the diagnosis.
Even those who have not participated can pick up and say. Nobody. How many found it difficult? Okay.
But at least out of that 16, what we assessed, many, at least 50% was there, at least half of the score, and the 5 have responded very well in the quiz, so that will be announced later. But so it was a good thing, like those who have attended the workshop and those others who, at least they are knowing the subject, they are picking up the findings. So we'll tell the answers right now.
Yeah. So note, we'll make a note next time, Hiren. We have to make the quiz easier. They all say it's difficult.
Display setting में कुछ है?
full swing पे ही है.
ये क्या आ रहा है?
यहाँ से नहीं आएगा. Touch kid.
Oh wow, okay, great.
Okay, so this was the question. There's a 1-week-old baby in the NICU with respiratory distress, saturation not improving after intubation. Correct. Excellent. So that's very easy then. This is false news that the quiz was tough. So the answer is misplaced endotracheal tube. As we can see here, the tube is in the esophagus. So you can see the lucent stripe of the trachea anteriorly and the tube is behind that. So it is in the esophagus. So what do you do next? You reintubate and check the saturation again. So this is a quick reckoner for all the lines and tubes that you can check in the chest when you get a chest x-ray of a sick child. So there is an easy rule of 2. So the endotracheal tube should be 2 vertebrae above the carina. Okay, so if this is the carina, it should be 2 vertebrae above. The central venous access catheter should be 2 centimeters below the carina. The nasogastric tube should be 2 intercostal spaces below the diaphragm. So if you see the diaphragmatic shadow, it should be 2 intercostal spaces below. And the chest drainage tube should have 2 points inside the thoracic cavity, that is the tip, and 1 additional hole should be within the thoracic cavity. So this is a simple way to check whether all the tubes and lines are in place. So the next question, a 2-year-old child with sudden onset of cough and respiratory distress. Excellent. So this was a unilateral lucent lung. So the differential diagnosis of a unilateral lucent lung, basically a unilateral lucent lung suggests that there is partial bronchial obstruction forming a ball valve mechanism where the air goes in but it cannot escape out. So one of the common causes is a foreign body, especially in this history of sudden onset of cough and breathlessness. And if it is more chronic, you can suspect the Swyer-James-McLeod syndrome. But in that case, usually the lung volume is small because it is a post-infectious sequelae or a bronchiolitis obliterans. Excellent. So this was a left bronchial foreign body.
So anybody knows, like when you are suspecting this kind of air trapping or obstruction, what are the other views that you can take to confirm that there is some sort of air trapping in that area on a radiograph?
Good, very good question.
So you can take some sort of decubitus or a dependent position. So you have to put the left side of the body down, rest of the chest, and still you can see that areas of air trapping persisting, that lucency is persisting. That means that there is some sort of anatomical structure L block proximal to that part of the lung. So that is a good confirmatory test to suggest that there is some sort of proximal block when you put that part of the lung into dependent area. Because when you put the normal lung into dependent area, it will show volume loss like a expiratory film like kind of thing. So it will show reduction in volume. But there is persistence of volume increase in that lucency and there is no volume loss. That indicates there is some sort of anatomical obstruction, right? Next.
Okay, so the next question is again very simple. So the diagnosis is correct, hyaline membrane disease or neonatal respiratory distress syndrome. So the typical findings of hyaline membrane disease is this hazy and granular opacities with that typical ground glass appearance, a smaller lung volume and a bell-shaped thorax, and it typically presents within first few hours of life. So you can see all those granular and hazy opacities in both the lungs, and it is typically bilaterally symmetric. So you know that this is some sort of diffuse lung disease. So this is just again a quick reckoner. So when you see a neonate with an abnormal chest x-ray, try to see, or rather any child with an abnormal chest x-ray, so try to see if the abnormality is in the lung, pleura chest wall or the mediastinum. If you find that it is in the lung, then see whether it is a focal or a unilateral abnormality or if it is a diffuse bilateral abnormality. So this was diffuse bilateral. So if it is a unilateral focal abnormality, we can think of the congenital structural abnormalities in a neonate. Whereas if it is a bilateral diffuse abnormality in a neonate, you're going to think of these 3 conditions: hyaline membrane disease, transient tachypnea of the newborn, and meconium aspiration syndrome based on whether they are preterm, term, and the history. Okay, so for this condition, diagnosis should be made on a chest x-ray and the babies should never be subjected to CT scan for this. Okay, so this is the difference between transient tachypnea of newborn, where you see these streaky hilar opacities and a whiteout type of lung picture, which reverses within 48 to 72 hours, whereas a hyaline membrane disease will not reverse on its own. It will need surfactant treatment.
Just a few words. So the clinical history will be different. You guys know that. TTN will have different cesarean section and underlying diabetes. So that will be a clue towards that what we are dealing with. And hyaline membrane will have obviously the preterm status. So based on that, and looking at the lung volume, so here you can see that definitely the lung volume will appear smaller in the hyaline membrane disease as compared to the TTN, right? So moving on to the next question. Here I think many of you could not pick up the abnormality. So he's a 3-month-old child who had inconsolable crying and some recent history of cold and cough 1 week ago. So, oh, excellent. So yeah, many of you have answered as a bronchiolitis. Few of you have answered as a pneumothorax or right-sided pneumothorax or something. But for pneumothorax, you can see the vascular markings inside, so it's not a pneumothorax. What we wanted to show you that to focus on this finding. So as Dr. Subhadish sir has taken yesterday X-ray, and as you should be aware that when you are looking at the chest X-ray, please look at the bones also. And you can see that there is some sort of bulbous projection of the posterior end of the ribs. So these are the common site for a child abuse or a non-accidental trauma. This indicates some sort of old fracture. They are multiple. They are not single also at multiple locations. So that also indicates that these are some sort of chronic old fracture. So what you should do next? First of all, that you have to tell your pediatrician that there is some suspicion of this thing and do the whatever legal procedures are there. But from radiology, we would encourage you to do the entire skeletal survey to look for additional areas of fractures which will increase the probability and confidence in radiologist to give as a more high likely of the non-accidental trauma. So there are some this kind of high specificity findings on radiograph. Few of them will be showing in the different image. You can take a snapshot of this, that when you see that highly specific finding, for example, metaphyseal fractures, the posterior rib fractures, the scapular fracture which requires high force, sternal fractures as well as the spinous process. So these are the fractures which you don't commonly see after a fall. They require high impact trauma to develop those kind of fractures. So these are highly specific for the battered baby syndrome or non-accidental trauma. Just wanted to show how to diagnose. So these are the classical metaphyseal fracture, which is also known as bucket handle or corner fracture. And look at the rest of the bone. The rest of the bones are normal in density. So you also have to rule out other underlying systemic thing like osteogenesis imperfecta or underlying scurvy, which also have this kind of metaphyseal and some sort of corner or widening. So rule out those things. And if you see that otherwise the baby is normal, but we are seeing this kind of fracture, then you should raise the possibility. In the skull also, when you see that the fractures are there, multiple bilateral, and they are crossing across the sutures. So that is also underlying suggestion of that the child is having some sort of high impact trauma, which is a sign of child abuse or a non-accidental injury, right? Yeah.
So this is the 10-month-old with failure to thrive, respiratory distress and cyanosis. I think this is a spotter. Correct. So supracardiac type of TAPVC, and this comes with the snowman sign. So this type of TAPVC is the most common type, and this is the hemodynamics where the veins typically form a common chamber and they drain into the innominate vein. That is why you get the vertical vein which goes into the innominate vein gives you this shadow. So you get this snowman appearance. And also what you can see on the chest X-ray, you will be able to see these dilated vessels within the lungs. So that is suggestive of the venous congestion because of the obstructed supply, because now the venous supply is also going to go to the right heart and then it has to go through the left heart through a shunt. So there is always some level of obstruction there, either at the vertical vein or at the level of the shunt. So you will have this type of a picture.
Just one more comment. This is one of the conditions in which the child will present with cyanosis, but on the radiograph you will be seeing enlarged vessels. Usually what we see enlarged vessels, PDA hoga, VSD hoga, which are left to right shunt and which doesn't have cyanosis. So this is one of the clue that when the child is like cyanosis and you are seeing this enlarged vessels still periphery, that indicates that there is some sort of anomalous pulmonary venous return. Yeah. So here you had been provided this kind of two imaging scenario plus clinical history also is different. So the first case has come up with the acute onset high-grade fever and cough for last 4-5 days. And the second case is like some sort of adolescent girl who had come with low-grade prolonged fever and chest pain. So what is the difference between two radiographs? So the question A, what do you feel? This is what? Excellent, empyema. And what is the second thing? No. So this yeah, so that's a diffusion. So we wanted to make you understand that how to at least raise the possibility of empyema and how to diagnose pleural effusion on chest X-ray. So there are some signs or there are some observations that you should be aware about. That usually the empyema, it's a loculated fluid or pus. So that loculated fluid will cause mass effect on the underlying lung parenchyma. So that will be seen as this kind of lenticular shape inwards. So when you see inward convexity, that indicates its loculation and mass effect that is commonly seen with the empyema. When you see that inner side concavity, that means that there is no mass effect, it's just effusion which is large in amount, which is covering the lung parenchyma. So that is kind of a meniscus sign or concavity inside. That indicates it's more likely to be a simple fluid rather than the loculated fluid or rather than loculated empyema. Yeah.
Just one more clue on this. See, over here you can even see the upper lobe has got these opacities, and there is, in spite of the effusion, there is slight reduction in the volume. So this was obviously some sort of reactivation tuberculosis giving rise to that pleural effusion.
Yeah, so those who missed yesterday's workshops for them, like when you see empyema on USG, USG is a great modality because many times, see, this is a corresponding CT image. So you don't see much complexity on CT scan. It just shows some sort of pleural fluid with some peripheral, this kind of enhancement of the pleura, thickening of the pleura. So when you see this kind of enhancing pleura in periphery with central hypodensity, this is called a split pleura sign, which is pathognomonic for the empyema. But if you want to assess the complexity, that how bad is empyema, how complex in terms of debris, in terms of septations, you should always use USG or maybe MRI. But most of the time USG solves the problem. So you can see that the same patient had very thick debris inside. You can see that there are thick septations within the pleural cavity. So that looks like more of a very severe variety of empyema, which should go for the decortication, right? And this is an example of anechoic fluid, that is the pleural effusion, right? So you saw the example of effusion versus empyema on different imaging modality.
Okay, so this is a 7-year-old child with recurrent wet cough without failure to thrive. So what is the diagnosis? So
first of all, where is the pathology, like on radiograph?
Yeah. No, pathology a lot of people have picked up, but
Yeah.
they have given the wrong answer.
Right side, left side? Right side problem is there, okay.
Yeah, right paracardiac region. And if you could not pick up on chest X-ray, you give the corresponding CT also.
See something.
So first tell me the diagnosis. Follow the question serially. What is the diagnosis?
Seeing a vessel, there is a contrast going through the right.
That can be differential, but you haven't provided CT scan also.
Yeah, that is why we have given the CT scan. Yeah, very good. So this is a pulmonary sequestration, and you need an angiography to prove that, because you see the anomalous vessel coming straight from the aorta to that part of the sequestration. So this is a pulmonary sequestration, and the CTPA, CT pulmonary angiography, helps with diagnosis. So these are the brief 3 types of sequestration: intralobar, extralobar and extralobar subdiaphragmatic, which you may see outside of the thoracic cavity. And this was the typical intralobar sequestration, which you see in the lower lobes. We'll just skip this
Just
for
to
sake
make
of time. Yeah.
So here is one 8-year-old child with history of recurrent wet cough. I just want to make you first identify the abnormalities, like what are the, what is the diagnosis? X. Yeah, very good. So, but I was like slightly disappointed because many of you have not picked up these findings. So basically, first the thing is that you are seeing dextrocardia. The cardiac apex is pointing towards the right side. If you see here in the lower zones bilateral, there are some. Sir?
Stomach bubble. Stomach bubble is
Yeah.
also on the right side. So
Yeah,
that's
situs inversus also. And then there are some distinct lucencies with bronchoscopal thickening rather. It's a bilateral lower zone bronchiectasis, right? So the constellation of all these findings, situs inversus, dextrocardia, lower lobe, pardon? Cardiogenic syndrome.
Not PCD. PCD means there is no dextrocardia.
Yeah, PCD will not have dextrocardia, situs inversus. When you see this kind of bilateral lower lobe bronchiectasis plus dextrocardia plus situs inversus, you should suspect cardiogenic syndrome.
The only thing we withheld was 8-year-old male. If we had said male, then it should definitely be.
Why are you saying PCD will not have? So this cardiogenic is a subset.
Correct.
Yeah.
Correct. But
Yeah,
I'm
It's a
saying
variety of this.
correct. But I'm saying that the cartigenous is the one that the subset which has the situs inversus. No. I mean the general variety of PCD will not have the. It's only the cartigenous type. Of course, the etiopathogenesis is severely described. Yeah. Correct.
In utero, the motiles, the motions
Correct.
are not working. Therefore, you get situs inversus.
It's an anatomical abnormality. It is acquired. It is not genetic. It is acquired. Because these are not working, that's why there is
situs inversus.
The underlying problem is
Because there are two types of cilia, one which do the clearance and the others which actually rotate inside to cause the heart to be on the left side.
Okay.
So that
the primary cause is PCD.
So, madam, even one of the 4 criteria is situs, no? Even in a
Yeah.
Yeah.
This is a subtype of this.
Yes.
So that's what this is. This image depicts the.
Yeah, so you should have at least triad of this thing. The child also have a recurrent sinusitis because of the.
But ये radiologist को ज़्यादा information मत दो. They will displace us. They don't do much.
Ma'am, actually we are worried that you guys will take all our.
Anyways, you all see the patient. Now you all will start seeing the imaging also. We've taught you too much. Bye. We will be thrown out, not the other way around.
थोड़ा ना इसने sequestration.
Yeah. So next case, child with sudden onset respiratory distress and admitted in PICU. So what are the difference between these two radiographs? Explain the two lines.
Right sided pneumothorax.
No, the right side pneumothorax and left side. This one. Pardon, sir? So any particular name is given for this pneumothorax? Yeah. So we wanted to highlight and identify that thing that from simple pneumothorax to tension pneumothorax, how the imaging difference you should see. So in the tension pneumothorax, there will be mass effect. So there will be bilateral shift. The underlying lung also will be completely collapsed, and the diaphragm and CP angle, everything will bulge downwards with the pleura being containing only air. So other your congenital malformations will rule out because you are not seeing any vascular markings through that area. So it's a pneumothorax only. The second case also is pneumothorax. When you have this kind of mild or moderate variety of pneumothorax, you will see just this kind of linear vertical line, which is called as visceral pleural sign. That is also 100% specific for the pneumothorax, but that is seen in mild moderate time. When it's getting like this kind of tension, then it's be labeled as a tension pneumothorax. In addition, you can see there is some sort of air in the soft tissues. Yeah. Excellent. So there is air surrounding everywhere. Yeah. So pneumomediasis plus surgical emphysema. Yes. Now I am happy that a lot of you are making enthusiastic answers.
So tension pneumothorax is actually an emergency, so it should not be missed because immediate placement of intercostal drain is required. So it should not be missed at all. This is of course a very severe one, but even in there's a lot of air here, but even in the smaller pneumothorax you should not miss that. Okay, now this is a 3-month-old with respiratory distress and non-bilious vomiting. So what is the diagnosis? I think some people have written it, but so what is the answer?
Yeah, so surprisingly, many of you have correctly answered.
No, but then they have written diaphragmatic hernia. Okay, so the answer is a hiatus hernia. Okay, so what is the difference between a diaphragmatic hernia and a hiatus hernia? So in a diaphragmatic hernia, you would not see this diaphragm which you are seeing over here, because in a diaphragmatic hernia the diaphragm itself is deficient. But in a hiatus hernia, it is just the herniation through the hiatus where the esophagus passes. So there are 4 subtypes of hiatus hernia: sliding, paraesophageal, mixed, which has both sliding and paraesophageal, and large congenital, which is this variety where the entire stomach is in the thoracic cavity. But here you are clearly seeing the diaphragm, which is intact. So that is not a diaphragmatic hernia, it is a hiatus hernia. Okay, and when you put
Differentiated from an eventration.
so in an eventration, the diaphragmatic level will be higher than normal, but none of so this is the diaphragm on the left side, and this is the diaphragm on the right side. So yeah, it is a little hazy, but you can yeah, it is a little hazy, but it is intact. And when you see when the where the nasogastric tube has been put, you can clearly see, because the air has been decompressed, so you can clearly see the diaphragm is intact. So in eventration, the diaphragm is at a higher level, but there is no herniation of any content into the thoracic cavity in an eventration.
That madam, full stomach.
Yeah, this whole bubble basically in the large canal, whole stomach goes through the hiatus into the thoracic cavity.
Clinically, it becomes like a CDH, except that the diaphragm that you said should
So,
be
like you have done your role and you have picked up at least some diaphragmatic hernia.
Yeah.
Now, after all this invasion, we'll tell that which variety.
So it is just the surgical approach that changes. No, in a diaphragmatic hernia, you have to put a mesh and everything. Over here, you just have to suture the.
On the right side, you see on the right lower zone, everything it is very easy. What is that?
Because that's all the herniation of the stomach. So this large congenital type also has propensity for volvulus of stomach. It also has propensity for short esophagus. So it is basically the stomach shadow.
Yeah. So this entire thing is stomach shadow. Sometimes it gets twisted and goes into volvulus also.
Yeah.
Yeah. Yeah. This. Second last question: 6-year-old child with recurrent fever with wet cough. So we wanted to highlight first again, identify the problem and where is the problem, and if you can think of any imaging sign. So wanted to highlight this thing that many times this kind of you will see some asymmetrical, very sharp shadow that is caused by the sternum. Like slight sternal rotation can cause this kind of, especially when the child is rotated also. So this you will see in many patients. That's not a collapse. Anywhere else? Yeah. So here is the. So anybody can tell like which sign you can put. Excellent. One is silhouette sign.
Silhouette sign, yes.
So
Yes.
what has silhouetted? What has silhouetted? Right heart border is silhouetted.
Yeah.
Very good. So that suggests what? When the right heart, middle lobe. Very good. So middle lobe. Okay. So any other imaging signs besides the silhouette? No, imaging signs. Yeah, very good. Of course, ma'am is correct. So tram-track sign, which you are seeing because of the dilated bronchi, which you see in a bronchiectasis.
So you are seeing this kind of tubular density.
Yeah.
Madam, right.
Sir.
The angle is also blunted.
Yeah. So that is there. The findings are there. So many findings are there, but we wanted to highlight this thing.
But uska sign nahi hai sir.
Anyways,
Imaging sign.
so when you see this kind of localized areas of collapse with the bronchiectasis, then you should rule out some sort of either some central airway obstruction which is causing some that block to that area. For that, CT scan was done, and CT scan revealed, you can see that the patient had both the middle lobe as well as lower lobe showing areas of bronchiectasis and collapse. If you see that this is the right lower lobe bronchus which is showing this filling defect. So that filling defect was looking like foreign body, and endoscopy it came out to be a custard apple seed, right? So this was missed probably. That's why you are seeing chronic lung damage, bronchiectasis.
Because of the recurrent infection, and this is a very important sign also, the bronchus cutoff sign. So usually you should be able to, like you can follow the bronchus here into the lung parenchyma, but here you cannot. So it is cut off. So that was because of the foreign body obstruction. So of course, if you mentioned any of the two of the three signs also, you have got it correct. And this is the last case. 12-year-old boy with abdominal pain and high-grade fever since 4 days. So what is the diagnosis and what is the pathogenesis of this condition? So I can just point to the to the abnormality. So this is a radio density. It is round in shape. So this is a
hemorrhage with IgA vasculitis having pulmonary hemorrhage.
I saw a couple of answers saying that, but how can we be so specific about that IgA vasculitis?
Abdominal pain was the presenting symptom.
No, but sir, every pneumonia comes with abdominal pain, so I don't know.
4 days. It's only since 4 days, no? See, vasculitis and all would have been a more chronic condition.
HSP is acute presentation with stomach pain, severe pain. Sometimes you require steroids or pediatric vasculitis.
But high grade fever?
This round opacity.
Yeah.
It's a localized lesion.
Yeah.
Vasculitis. Vasculitis is more generalized.
Correct. So yes, this was a round pneumonia, and round pneumonias, as we all know, usually seen in children less than 8 years because of the underdeveloped collateral ventilation pathways of the pores of Kohn and canals of Lambert. So because of that, the infection stays localized and forms a round opacity instead of the typical segmental or lobar pattern that we see.
So abdominal pain was a that's
Pneumonia.
Referred pain. You can get any pneumonia.
So yeah. So these were the 12 questions that we had.
And now we can.
Pneumonias, I feel like many pneumonia
So we had got some sort of between 15 to 20 entries. In that, the top 5 those who participated, we're going to announce their name. So starting from the bottom, the 5th rank was, you can announce it.
Dr. Sharmila Mathye.
You can stand up like so that we can.
Who is Dr. Sharmila? Not there. Okay. Number 4 was Dr. Amir Jabani. Sorry.
Oh wow, she is our student only.
Excellent.
Good. You can sit down. So we are giving prize to first 3, but this 5 people have we'll give tomorrow.
Okay, so now in position 3 is Dr. Suprita with 12 points.
Dr. Suprita.
Excellent. She attended our workshop yesterday. Very good. Come and take it.
No, she's a DME student, not radiology fellow. Radiology fellow, I would not be happy with this scoring.
This totally at 12. Okay, and in position 2 we have Dr. Vishal Samaga. Come on. You don't want your prize, then we'll take it home with us.
Vadia, he's from Vadia. He's a pulmonary fellow if I don't mistake. Yeah.
And in first place, you can give a roaring applause to Dr. Gautam Sapre.
So, but I wanted to meet and see him because he has scored almost all correct, boss. Like he was like a radiology.
And your answers are also very descriptive, very perfect, very nice. We are very impressed.
Sir, what do you do, sir? Sir, what do you do?
Private practice. I did my MD from Wadia, so thanks to my teachers. Then I attend CAVs by Dr. Indu and other people also. So I keep updating my knowledge. Helps nice to, probably I should have attended yesterday's workshop, so I could have got more.
His answers were like a radiologist reading a lecture.
Yeah, absolutely.
That much detail and that much clarity.
Yeah, that's what I was going to say. He's going to give us a run for our money. We'll be replaced soon.
And lastly, thank you organizer for giving us the opportunity to come here and show some cases.
Thank you everyone.
So I know, thank you to everyone who sat till the end and took the maximum benefit of all the knowledge we have. Just end with a brief vote of thanks. I would like to thank the entire team of Mumbai IAP, the organizing team of AIRCON 2026, Indu ma'am, IAP, respiratory chapter, and all the dignitaries who are here and faculty who were here to grace this occasion. Our amazing radiology team who put together this quiz, put together the workshop, our support staff, AV team, my colleagues Gitesh and Abhinaya, our caterers and everybody who made this possible. Thank you so much for coming here.
PIP led by Dr. Kasla, Dr. Nehal, Dr. WP, Dr. Shika, Dr. Sushma Savit, and of course my pillars of strength. 1, 2, 3, Dr. Hiren and Dr. Sonal, they are my pillars of strength. And I give deep gratitude for all my faculty who came from so far at one call, and all of you delegates, you guys rock. Thank you so much.
Thank you, SRC, everyone.